have an interesting session ahead. We'll have two case presentations, postgraduates, followed by an Indian literature review on an important topic, acute liver failure, followed by a lecture from a distinguished faculty, Dr. Malay Sharma, and then followed by a panel discussion. So we have a loaded session ahead of us. So I welcome you all to this meeting, and I'll request Dr. Prem Kumar, President, to give us welcome address.
Respected teachers, senior colleagues, junior colleagues, dear students, on behalf of the TNISG chapter, I welcome you all for this CME monthly CME program. And today, as you all know, this is in combination with the CME program conducted by the Kaveri Hospital, and we have roped in a couple of consultants who have come for this program in Dr. Vikram Bhatia and Dr. Prakash Akarias, and they are going to take part in the panel discussion. I'm sure it's going to be an academic feast. Without wasting much time, I request the chairpersons, PP Sir, Padmaravas Padmanabhan Sir, Dr. Shanti Vijayaraman and Ram Kumar to come out to the dais and take over and conduct the proceedings.
To each and every one of you. At the outset, I thank the organizers for giving us opportunity to be here. I request the first presenter, Dr. Anbu Kritika, Department of Medical Gastroenterology, SRMC, to present her case, an interesting case of Delhi in a patient with steatotic liver disease. Please.
Present here. So I'll be talking about an interesting case which presented to our OPD. A 59-year-old lady initially presented to her regular physician in the August of 2022 with complaints of nausea on and off for 6 months and weight loss of almost 18 kgs in 1.5 years. No history of fever or GI bleed or jaundice or abdominal pain. She was a diabetic for more than 15 years, hypertensive for more than 15 years on medications. She also had a history of paroxysmal atrial fibrillation in 2017, for which she was put on medications. And then again in 2019, she was treated for atrial fibrillation with congestive cardiac failure. An angiogram done at that point showed normal epicardial vessels. So she was continued on her regular medications. On follow-up after 6 months, echo showed a normal ejection fraction. Subsequently, the patient did not visit any other hospital and she was just continuing her regular medications. She is a vegetarian, nil addictions, no surgeries or blood transfusions, and no history of any CAM intake in the past. This was the evaluation done by her general physician. So the LFT pattern showed a hyperbilirubinemia with elevation of SGOT, alkaline phosphatase and GGT. Also there was an AG reversal. They went ahead and did a CECT abdomen which showed an enlarged liver, no liver lesions, gallbladder calculi was seen, spleen was enlarged but no free fluid. They also went, because this showed a cholestatic enzyme pattern, they went ahead and did an MRCP also, which did not show any IHBRD, but it showed a mild fatty liver with cirrhotic appearance and mild ascites. With these findings, she was referred to us. In SRMC, the first consult in our OP was on 29 September. On examination, the patient was conscious, oriented, afebrile, comfortable at rest. Pallor was present, but vitals were stable. Per abdomen was soft, there was no free fluid. So the initial clinical impression at this point was a chronic liver disease, probably mast related with activity, and significant weight loss and diabetic and hypertension were her comorbidities. The investigations done in our hospital showed an hemoglobin of 9.5. ESR was elevated. Again, the liver function test panel also showed an hyperbilirubinemia with increase in cholestatic liver enzymes and an AG reversal. INR was normal and the UJ-scopy done at this point showed no varices. So when we worked up for the liver disease, the viral markers were non-reactive. Autoimmune hepatitis panel was negative. Ceruloplasmin was normal. Fibroscan done showed a F4 fibrosis with a transient elastography score of 75. So the diagnosis at this point was a compensated CLD, mast cell related, with elevated liver enzymes, predominantly with a cholestatic pattern. It was managed conservatively with UDCA and the regular standard of care. She was asked to follow up after 1 month. On follow-up after 1 week, on 1 week, she was still symptomatic, continued to be nauseous and had marginal weight loss also. The repeat LFT at this point also showed no significant change. So in view of the cirrhotic liver with deranged LFTs, with otherwise stable parameters like normal INR and no varices, we went ahead and after explaining the risks, did a liver biopsy. The liver biopsy showed an hepatic and canalicular type of cholestatic liver injury with fibrosis. But the cause of this cholestatic injury could not be clearly defined at this point. The patient was managed conservatively and advised to follow up after 2 weeks. But due to personal issues, she could not return in the 2 weeks in her follow-up date. She came back 5 weeks later with abdominal distension at this point, which was almost present for 15 days, gradually progressive and associated with abdominal discomfort also, with swelling of both lower limbs. Also, she had an episode of fever, low grade, no history of GI bleed or altered behavior or sleep disturbances. So at this first decompensation episode, she was admitted. On examination at this point, she had bilateral pitting pedal edema and abdomen was distended. Otherwise, the vitals were stable. Investigations done at this point again showed low hemoglobin, ESR was elevated. The liver function test showed a similar cholestatic pattern. Ascitic fluid analysis showed an ISAG low protein ascites with no features of SBP. To rule out volume overload due to other reasons, an echo was done, which was normal. UJ-scopy at this point showed prominent esophageal veins suggestive of early portal hypertension. The ultrasound abdomen showed chronic liver disease with significant ascites. So this was the timeline. She initially presented with these symptoms in August. She was stable till almost September. Then she decompensated in November. She was managed with large volume paracentesis, diuretics and salt restriction and the regular standard of care. The patient, we noted that the patient was still continued on amiodarone for her paroxysmal atrial fibrillation. She had been taking this for almost 6 years. Since she did not improve despite the optimal therapy, we suspected that the decompensation and worsening of liver enzymes was due to this amiodarone intake. Since the cardiologist had so far asked her to continue the amiodarone, we got a cardiology consult and then the amiodarone was stopped. She was discharged with the other regular standard of care, salt and fluid restriction. On follow-up after 2 weeks, her LFT was normalizing. She appeared clinically better. Ascites and pedal edema had subsided to a large extent. This was the LFT pattern on follow-up. On follow-up after 1 year, no features of any ascites was there. She was completely dry, no pedal edema, and this was the last LFT. So the diagnosis is a mast-cell-related CLD complicated by drug-induced liver injury secondary to amiodarone, moderate ascites which improved, no SBP, mild portal hypertension with no hepatic encephalopathy or acute kidney injury. The MELD at the time of decompensation was 12, which came to 7, and CTP was from 8B to 5A. This case is being presented because it was an unusual presentation of a rapid worsening of a stable CLD due to chronic amiodarone toxicity, which we initially missed, and improvement once the drug was completely stopped. So amiodarone toxicity, amiodarone is an highly lipophilic and analog of a thyroid hormone, which is concentrated mainly in the hepatocytes with an half-life of about 6 months. The mechanism of amiodarone toxicity, it's mainly, the principal metabolite is desethylamiodarone, which produces reactive oxygen species. This leads to hepatic triglyceride accumulation and microvesicular fat steatosis in the hepatocytes, and also direct damage to the lipid bilayers and mitochondrial injury. So the amiodarone toxicity can be of two types mainly, chronic and acute. Chronic is most common when the patient is taking 200 to 400 mg amiodarone for a long period of time. In this also, 50 to 50% of patients present only with liver enzyme elevation only. Clinically apparent liver disease occurs in less than 1% of cases. Acute amiodarone toxicity occurs only when it is given IV, mainly the cath lab in very high doses in severely ill patients. So chronic amiodarone toxicity seen in patients on long-term oral therapy. In the majority where only liver enzyme elevation is present, in these cases the AST is elevated to less than 2 times the upper limit of normal, and despite continuation of the amiodarone, these LFT abnormalities resolve by itself. So it is recommended to discontinue the therapy only if the enzyme levels are more than 2 times the upper limit of normal. Rarely, in 1% of cases, clinically apparent liver disease occurs with symptoms as nausea, weight loss, mild jaundice, mild to moderate elevations in AST, LT, and hepatomegaly. This can progress to severe form of a liver disease with fall in serum albumin levels and acute end-stage liver disease. The pattern of enzymes can be cholestatic pattern. Our patient had these similar symptoms: nausea, weight loss, mild jaundice, hepatomegaly, and finally decompensated with ascites. The liver biopsy findings in these cases, usually in the early cases, it is only ballooning degeneration and mild inflammation with micro and macrovesicular fat. Later, when the inflammation is more severe, there are variable amounts of fibrosis. Mallory bodies can be seen. Only under the electron microscope do we make out the phospholipid-laden lysosomes, also known as phospholipidosis. These phospholipidoses in the light microscopy will appear only as granular cells. So this was the histopathological slide in a patient with chronic amiodarone toxicity. There are features of bridging fibrosis and regenerative nodules suggestive of liver disease, chronic liver disease. But the main thing indicating amiodarone toxicity were the Mallory bodies indicated by the arrowheads, the multiple arrowheads there, and the ballooned epitocytes indicated by the arrows. The picture on the right is an electron microscopic picture which is showing the whorled and lamellar inclusions in the lysosomes. CT findings, this is usually an incidental finding. The CT, because amiodarone is an iodinated compound, CT of the abdomen, that is a plain CT of the abdomen, will show increased hepatic attenuation or density. The second picture is a picture of a 56-year-old male who has been on 400 mg amiodarone for more than 8 years. In this case, the liver is showing increased attenuation, that is almost 145 Hounsfield units when compared to the kidney and the muscles, which is showing only 40 Hounsfield units. But this is just an incidental finding. It has no correlation with the gastrointestinal symptoms or the abnormal hepatic enzymes. And most of the time, once the amiodarone is stopped, this resolves by itself. So acute amiodarone toxicity is very rare, only seen when amiodarone is given intravenously in very high doses, especially in elderly patients. In this, the liver enzymes will be markedly elevated to more than 100 times. And usually, the liver injury reverses quickly with stopping the infusion. This is attributed to an idiosyncratic toxicity and hypersensitivity to the vehicle, that is the polysorbate 80. In these cases, when an autopsy was done, they showed more features of ischemic hepatitis than anything else. Thank you.
The metabolic alcoholic steatotic liver disease.
Yes, sir.
Was it diagnosed at that time, 2017?
No, sir. At that point,
your topic is delay in an already existing
steatotic liver disease, sir.
Was it?
No, sir. And when 2017, she was mainly seen by the cardiologist. At that point, they had not diagnosed any liver disease, sir.
So, while the patient was on amiodarone, was there any evidence for steatotic liver disease? No.
No, sir. At that point, no, sir. This was diagnosed later.
What is the present biopsy is also doesn't show any microvascular
facts. Yes, sir.
That is a little bit peculiar also.
When we discussed it with the pathologist, what they said was it was very early changes. Probably nothing can be seen because they did not find any particular features of amiodarone toxicity in that slide.
In the absence of microvesicular steatosis, can we tell amiodarone toxicity?
Yes, sir. It can happen, sir. There are case reports where it can happen.
I think, I think the history is most important, no?
Yes,
because I'm sure Dr. Ganesh will remember, we had presented one particular case which was just identical. I think what most important message is collect the list of all the drugs the patient is on. I think that should be level 1. And then just get into the pharmacare. So that history of, I mean, moment you presented, I knew it was amiodarone toxicity. Because it's cumulative. Over a period of time, it happens. Okay, moment you stop the drug, in fact, I told the cardiologist, please stop the drug. Because it was well known that that was the cause. And I remember presenting this case in one of our master classes at SRMC. It's actually a straightforward diagnosis. The first slide tells you it's amiodarone toxicity. Thank you.
Mike. No. Not audible, sir.
It is only it is not at all a metabolic dysfunction associated, because amiodarone, you said, causes steatosis, right? So it is totally a amiodarone related.
There were features of fibrosis in the fibroscan as well as the MRI
So this
done.
amiodarone can also cause chronic liver disease. So you don't, at the moment, I think you have to treat it as
We mentioned it
amiodarone
because it fit
related.
under the criteria for the MASL, the metabolic cardiometabolic
But it is
criteria.
a process of exclusion. Since the process of exclusion, I think you have to keep it as a.
Okay.
Anyway, it's a very good presentation, Anbu. Thank you very much.
Thank you.
From the Department of Medical G, Madras Medical College, an infectious implosion in an IBD minefield.
Was admitted in our ward. So our patient story starts way back in 2019. He was a machine operator by profession and he was working at Dubai when he had an index presentation of a painful diarrhea. He had around 8 to 9 episodes per day with blood and mucus in the stools. The diarrhea was watery in consistency, insidious in onset, foul smelling, small in quantity, with nocturnal frequency, with urgency and tenesmus. He also had abdominal pain, which was on and off, insidious in onset, gradual and progressive, more in the lower abdomen, cramping type of pain, and the pain would just peak just before he used to pass the stools and get relief after he used to pass it. He never had any history of any fever or rash or any loss of appetite or loss of weight. He did not have any unusual joint pains or backaches. He did not have any redness of eyes. So taking the nature of his symptoms, he was evaluated at Dubai itself and his basic investigations were done and he was advised a colonoscopy. And a full-length colonoscopy was done which shows diffuse granularity of mucosa with erosions with tenacious exudates. It was suggestive of an IBD ulcerative UC pancolitis type. So there they initiated him on tablet prednisolone 1.2 milligram as well as prednisolone 40 milligram 8 weeks on a tapering schedule. So he had a comparative relief at that time. It came down from 8 to 4 per day, but however blood and mucus was still there. Then in February 2020 he came back to India, but he was still symptomatic and he had recurrence of symptoms because the 8 weeks of steroid was over. So here, and he had an increase from a jump from 4 to 8 per day with blood and mucus. So here they again reinitiated him on the prednisolone program, a 40 milligram tapered schedule, along with azathioprine of 50 milligram plus the old dose of mesalamine of 1.2 gram. The stool frequency again decreased from 8 to 4, but however there was still blood and mucus persisting. So incidentally at that time he was also diagnosed as a diabetic and he was started on OHS. In March 2020 he had some vague epigastric symptoms and dyspeptic symptoms, for which fundal UGScopy was done and it showed some fundal and corporal gastritis. In June 2020, since his symptoms did not resolve much, he went to a tertiary care hospital where again he was subjected to a limited colonoscopy up to the splenic flexure. The report again showed a loss of vascular pattern, erythema of friability and erosions with a Mayo score of 2/3 and a UCS score of 4. It looked like a feature of a left-sided colitis. The histopathology was classical of our crypt distortion, cryptitis and crypt abscess with focal crypt loss. But however, there was no granuloma or any evidence of dysplasia. So here, already the old dose of mesalamine plus azathioprine was going on, plus he was added with mesalamine enema. But here also, he was never able to get complete remission. He always had 6 to 7 stools per day, blood and mucus on and off. Sometimes blood, sometimes mucus, but always he used to have a problem when he had stools. In January 2021, he had another flare in the form of diffuse abdominal pain, and this time the stools had gone to 13 per day. He was evaluated in the same hospital and his ESR and hemoglobin was normal and there was no drop in hemoglobin. A colonoscopy was done again at that time and there it showed the lesions was confined to the left side of the colon, predominant involvement of the rectum. So it looked again like a left-sided proctosigmoiditis. So here they had stopped the enema and they had started him on suppositories along with the oral mesalamine plus the plus the azathioprine. He was on regular follow-up for the next 1 year and every month whenever he went to get his medications, he used to be titrated, up-titrated or down-titrated according to his symptoms. So here also relative improvement, it came to around 6 to 7 stools per day, but again it was still mixed with blood and mucus, he did not have complete remission. In April 2022, he again went for a third opinion. This time for want of more clarity, he went to a medical college. There, the only thing they had done was they increased the azathioprine from 50 to 75 milligram and they told him to continue on mesalamine 1.2 gram BD. He was in regular follow-up for 6 months. Still on and off 4 to 5 blood and mucus stools was there, and symptomatic treatment. Whenever he had issues, he used to go there and they used to treat him. So taking into the nature of the disease, they thought he would benefit with biologicals. So they sent him to our hospital for an opinion regarding whether to start him on biologicals. So when he came to us, it was October 2022, and he came again with a flare. He came with 10 episodes per day with blood and mucus. This time it was with abdominal pain and fever also. On examination, he did have some clubbing and some mild pallor. But other than that, his abdomen was soft and there was no organomegaly. This was his investigation at that time. It was not very remarkable. His cultures also were negative. His viral markers were also negative. So at that time, we treated him with antibiotics, mesalamine and azathioprine. He did have a comparative relief, and the stools, which was 13, came down to less than 5. There was a little bit of blood and mucus, but still we thought, since he was referred to us for biologicals, we thought him to start him on the pre-biological workups. Simultaneously, full-length colonoscopy was done to assess the current state. The colonoscopy showed some loss of vascular pattern from the rectum up to the splenic flexure, and some free liquid was seen in the lumen. Here, when we did a colonoscopy and we were waiting for the histopathology report, an unexpected twist had happened. The patient was turned out to be CMV positive. So, and along with that, his histopathology report came as cryptitis with cryptos distortion, along with ovoid nuclei with intracytoplasmic internuclear inclusion bodies. So this was a clear case of CMV colitis. So this was the first implosion that this patient had. So this was the image with the inclusion bodies in it. So for the treatment aspect, we started him on injection ganciclovir for 300 mg for 21 days. He had a very good and significant improvement. The reduction of the stools came down to 2 to 3 per day, and his improvement, he had a good improvement in his quality of life, and he was able to go back to work. We put him on mesalamine and azathioprine, and we had just observed how he was coming about. In December 22, December 2022, exactly within a month or so, he again came back with a flare. This time 10 episodes per day, again abdominal pain, and on examination nothing much remarkable was there. We did a colonoscopy. Here again it showed a IBD, left-sided colitis. Right from the rectum up to the splenic flexure, there was a inflamed and there was few ulcerations and loss of vascular pattern. That time a DEXA scan also was done, and it showed osteopenia on the spine. So we thought this would be the ideal time, since he was already having multiple flares, to start him on biologicals. So on January 2023, we were successfully able to give him the first dose of infliximab, and we discharged him with a plan to review according to the infliximab program of 0 to 6 and every 8 weeks further. And we promised that he would be assessed every time he would come. On discharge, he was very good. He had his vitals was normal, his investigations were normal, and this was the medication we sent him post starting the first dose of infliximab. We started him on azathioprine 100 mg, folic acid, calcium, and mesalamine 1.2 gram BD. So he had very good significance, and his quality of life was really good, because this is the first time in his entire disease career that there was only stools that came down to 1 to 2 well-formed stools. There was no blood and mucus, so the patient was quite happy. In April 2024, by now the patient had completed almost 1.5 years. He was remission free, and he had come again after the 9 doses of infliximab. This time when he came, unfortunately, he had another very bad flare of symptoms. This time it was 9 to 10 painful stools, mucus and diarrhea was along with that, with urgency tenesmus, with a loss of weight about 5 kilos in a month or so. So on examination, he did have some dehydration and pallor with some clubbing was there. So other than that, his clinical examination was relatively normal. His investigations, the total count was definitely elevated. It was 12.6. Other than that, his viral markers and other values were okay. ESR CRP was on the higher end. So this was the colonoscopy that was done at that time. It showed full-length colonoscopy was done, and from the sigma 35 centimeters from the rectum up to the splenic flexure, we did have a complete loss of vascular pattern, and it showed a score of 3 with a left-sided colitis. So this was the video from the colonoscopy. As you can see, there is definitely edema, erythema, and some loss of vascular pattern. This was on the left side of the colon. There were a lot of erosions, some ulcers, and all the way up to the splenic flexure, just before the splenic flexure. Up to there, this was the image. And this is right from the splenic flexure onwards. It was a relatively healthy colon. There was no loss of vascular pattern or erythema or any unusual findings. Coming to the stool evaluation, this Clostridium difficile turned out to be negative. His cultures also was sterile and it was negative. But however, when we did a routine stool microscopy, it came out as trophocytes positive. Simultaneously, at the same time, his colonoscopy report, his histopathology report came, it showed some active proctitis, but along with that, they had given an additional information here, cytopathic effect with amoebic trophocytes. So as you can see, the patient's microscopy also had trophocytes, and it was also confirmed with our histopathology that trophocytes. So this is a case of amoebic colitis. So this was the second implosion that the patient had. So the treatment aspect, we treated him with anti-amiable drugs for 2 weeks. And he had a very good and dramatic improvement. His stools came down to 2 per day, well-formed stools. It was not associated with blood and stools. His quality of life improved and he was able to go back to work and he was very happy. Currently, the patient is right now on mesalamine, azothioprine and on the regular dose of infliximab. So just an overview about amoebiasis. So what we know so far is it is caused by Entamoeba histolytica. We have 4 types of species, of which histolytica, dispar, Moskowski and Bangladeshi, of which histolytica and Moskowski are known to cause active diseases, whereas Moskowski is known to cause it in children. E. dispar is non-pathogenic. It doesn't usually cause it. So who are the people at risk? Young age, pregnancy, corticosteroid malignancies, malnutrition, alcoholism, men who have sex with men and travel to endemic regions. So life cycle, it is relatively quite simple. Fecal contamination. Usually it is from the soil, it is contaminated through food and the cyst is consumed. It enters into the stomach, into the small intestine. The cyst will mature into a trophocyte. The trophocyte can invade and in the colon, it goes to the colon and it invades the mucosal barrier and it can cause tissue destruction. If it enters into the hematogenous route, it enters and it can cause deposits in the liver, the brain as well as in the lungs. So this is the pathogenesis. So basically it works by 3-4 mechanisms. First one would be proteineases, the secretion of proteineases by trophocytes, which will cause a direct erosion of the colonocytes. Then contact dependent mechanism where the trophocytes will actually be sitting on the colon and it can erode into the colonic mucosa. Then by programmed cell death, that is apoptosis. Then formation of amoebopause. Amoebopause is nothing but a ligand connection between the trophocyte and the colon, which can cause all your chemokines and immune cell infiltration that can happen. And finally, if there is a change in the biota, when there is a dysbiotic microbiota, it can cause intestinal permeability issues, disruption of the tight junctions, which causes your watery diarrhea. So clinical manifestation, mostly it is asymptomatic. They are gentle harbors of the disease and they do not suffer from the disease per se. If it is going to be acute or a subacute disease, they usually start developing it in 1 to 3 weeks. They will present with diarrhea, with blood and stools, with abdominal pain. If it's going to be a more severe type, like in fulminant amoebic colitis, it's going to be a life-threatening lower GI bleed without diarrhea, along with weight loss and fever. So coming to the diagnosis, most commonly we try to prove it with the simplest technique possible, that is the stool microscopy. We just take 3 different samples on 3 different days and we look for the trophocytes in the or cyst in the stools. And in the lab they use the iron hematoxylin or the weekly trichomochrome. The gold standard, which is the best accepted, is colonoscopy along with the histological examination, and we try to look for the discrete flash shape ulcers. Wherever it is available, we ask for a stool PCR and a stool antigen also. Treatment aspect, the most accepted and what we commonly practice is parmomycin, idoquinol and diloxanate furoate for luminal amoebiasis. For parmomycin, it would be 25 to 30 mg kg per day in 3 divided doses for 7 days. Diloxanate furoate, 500 mg oral, TDS we can give. So if it's going to be a mild disease, 10 days of metronidazole will do the trick and it will completely eliminate the disease. If it's going to be a more fulminant type of a disease, we'll have to give an empirical broad spectrum antibiotic along with the metronidazole. Metronidazole dose would be 500 to 750 by mouth 3 times a day. So this is the timeline of the patient, exactly what had happened. So the patient in November 2019, he first index presentation with blood and mucus. He was started on mesalamine and steroid. The next thing he did was, when he came back to India, he had a flare. There they started him on azathioprine in February 2022. Then after that, in March 2020, he had dyspeptic symptoms for which OGD was done. It showed fundal and corporal gastritis. In month of June, he had a second opinion from tertiary care hospital. There they stopped him. They started him on mesalamine enema for the left-sided colitis. Then, in the month of January 2021, he had blood and mucus again. This time left-sided proctosigmoiditis. This time they stopped the enema, started him on suppositories. In April 2022, he had another flare. Again, he was started on azathioprine. It was at 75 milligram. They considered whether to start him on biologicals. He came to us in October 2022, again with a flare at that time. At that time, we incidentally diagnosed him with CMV positive. At the same time, in December 2022, again he had one more flare in the form of having more than 12 episodes per day. But the drug compliance was very intact at that time. The CMV had resolved, so we thought this would be the best time to start him on biologicals. So we planned him in December 2022. We did the pre-biological workup, and then we started him on biologicals. In the month of January 2023, we were able to initiate on the first dose of infliximab. Then he again presented back with a flare. This time in April 2024. This time it was amoebic colitis. That was the issue. But by now, 1.5 years, he was absolutely in remission, and he had amoebiasis. In May, 100% resolution had taken place. So while brainstorming what header would be ideal for today's topic, I recalled the conversation that I had with this patient. He said, "Sir, treatment ஆரம்பிச்சதுலேருந்து கால் வைக்கிற இடம்லாம் கண்ணி வெடி மாதிரியே இருக்குது. இதை எப்படி நான் தாண்டுவேன்?" In other words, it roughly translates as, "Sir, from the time you started the treatment, every time you diagnose with me with something new, it's always like as if I'm walking into a minefield. How do I tide over this?" So from the patient's view, yes, he's right. It is like a minefield. Okay, so every time he walks, every time he diagnoses something, it's going to be a minefield. And his question is very valid. How do I survive this minefield? But more than a kannivedi, this is from a physician's perspective, this looks more like a saravedi. That means one episode after the other, one episode after the other, one episode after the other. So from the bird's eye view, when we look at it, it's not a kannivedi episode, it's more like this saravedi. It's a bijli type of thing. It's something that is constantly going to happen. So this is basically a saravedi type of pattern of IBD that is happening here. So the point of bringing this topic to this learned forum is only two things. One is, we want to just emphasize that amoebiasis is as equivalent a player as compared to the big dogs such as CMV colitis and Clostridium difficile in creating a flare. And whenever we have an IBD flare, we always tend to look at the usual suspect list, that is Clostridium difficile and CMV. But we tend to forget the forgotten suspects, that is amoebiasis. So amoebiasis has to be brought out of the forgotten list into the regular suspicion list. And the second thing which I want to convey to this learned forum is, we are at a predicament at this point of time. See, the patient so far has already faced, he has been twice treated for worsening of symptoms, steroids, everything. The second thing is, he has two episodes of an infectious flare, one in CMV colitis and amoebic colitis. Now our question here is, should we continue the biologicals? Because if you see from the timeline, it is a saravedi pattern that is going to take place. We just hope and pray to God that nothing happens to him next time. But if at all something is going to happen, can we do something today about the biologicals that will help him in the future? With that, I put up these questions here.
Good presentation. Thank you very much, Doctor. And also, CMV is not like a unexpected twist. It is an expected twist, right? Yes. Anyway, thank you very much.
So let's move on to the next one. Sir.
Davis Prabhakar. Not yet over. It's a good presentation.
Thank you.
And it's also nice to see that the patient stuck to you for so many years. And every time he had a flare, he came back to you. And every time you diagnosed infection. But you continue to treat him for UC. But every flare, do you think it was because of UC or because of infection? Number one. Number two, at any point of time during this 2019 to 2024, you took any surgical consult?
Actually, we did ask the surgical gastroenterologist.
Because UC is probably a recurring problem. In this patient, if he's had flare 3-4 times for infection, have you assessed after the treatment of infection whether the ulcerative colitis part is healing or not by colonoscopy. If it's not healing, then most likely there is a problem that he might come back with a flare, maybe because of some other infection or problem because of the disease itself. The only way to treat him is probably give him the option of a surgical option, because that is curable,
Yes.
isn't it?
Yes.
So any point of time you took surgical consult?
Sir,
This is a long history.
yes, sir. Before starting him on biologicals, we did ask our surgical gastroenterologist counterpart. Taking the age into consideration, we thought such a young age, if we
Young age only you have to take the consideration for surgery, no?
yes, sir. So
Isn't it?
yes, sir.
Thank you, sir. Actually, I had the same question and it's towards the learned audience. In today's era of biological, have you forgotten about surgery? It used to be something we always did with two consultations. So, in your esteemed view or anybody else, when should we now be considering surgery? This is now no longer discussed in all the high-flying IBD meetings. It's a genuine question. I do not know the answer. I'm asking
The
this.
patient, he should have a surgical.
Surgical.
I think as Dr. Vikram said, I think we should consider surgery because in 3 years' time it's pan colitis, right?
The first colonoscopy showed pan
with
colitis.
severe relapses and remissions, no? So I think at some point of time, within 3 years, he's going to land up with a colectomy. So I think that option has to be discussed. In fact, the younger the patient, I remember Dr. Surendran, first acute bloody diarrhea, he'll go for a total colectomy. And the patients are actually comfortable. They tell us, why did you not tell us about this? Actually, the patients tell us, why did you not tell there's a surgical option for management of these patients?
Sometimes if they are symptomatic for such a long time, they develop fecal incontinence, where surgery will become very difficult, where they might end up with a colostomy.
They might have clinical remission, but then histological remission may not be there.
May not.
Might be having venous disease. Ram?
Thank you, Dr.
Sir.
Davis.
To add on, with the advent of biologicals and the JAK2 inhibitors and all, the rate of surgical proportion is less than 1%. So if there is, yes, as ma'am advised us, if there is long standing pan colitis and all, if there is risk, yes, total proctocolectomy is the option. But with the advent of these biologicals and the tofacitinib and all, it has moved to less than 1% for the surgical consent.
There is a cost to biological, everybody cannot afford.
Thank you, Davis. We'll go on to the next presentation. It's a review of Indian literature, acute liver failure in India by Dr. Somnath Verma under Professor Padmanabhan Sir unit from Meenakshi Medical College, Kanchipuram.
Respected seniors, respected teachers and my dear colleagues. First of all, I would like to thank TNSG for giving us this opportunity. Under the guidance of Professor Padmanabhan Sir, I am going to present today acute liver failure review of Indian literature. This is my methodology. I have chosen the topic of from the INASL guidelines acute liver failure in 2020. After that, there are whatever the recent topics has been discussed in the PubMed Index journals. I have included those articles also. This is my overview of the review article, the definition, epidemiology, etiological, role of histology and management. First of all, coming to the definition, in 1969, first time the definition of acute liver failure has been given by Trey and Davidson, which shows the appearance of encephalopathy within 8 weeks of onset of acute hepatitis in an individual without pre-existing liver diseases. Since then, there are more than 40 definitions has been proposed, and all the definitions include acute liver failure, that is encephalopathy of any grade, coagulopathy or absence of pre-existing liver disease. To the underlying pre-existing liver disease, there are some exceptions there, that is chronic hepatitis B vertically infected, autoimmune disease or Wilson disease, and ACG include Budd-Chiari syndrome is also there. And all the definition will vary from interval 2 to 26 weeks. This is the different change in the from the onset of jaundice to the encephalopathy. Trey and Davidson included 8-week. American Association of Study of Liver Disease include 26 week of duration. O'Grady include 12 week of definition. INASL include a 4 week of definition. Coming to the subclassification of acute liver failure, they included as a hyperacute, acute and subacute. The time frame duration of less than 7 is a hyperacute, and probably this is because there is a risk of high cellular edema is there, but the risk of death is low. As compared to the subacute liver failure, where the duration is 21 to 26 week, where the edema is less, but the intermediate risk is high. Coming to the pediatric ALF definition, this is a North American British pediatric ALF study group definition 1999, where they are given the hepatic based coagulopathy, that is PT of more than 15, INR more than 1 point, which is not corrected by the vitamin K, or there is a PT prolongation of more than 20, or INR of 2, regardless of presence or absence of clinical encephalopathy, with the biological evidence of acute liver injury, or there is no evidence of any underlying chronic liver disease. Neonatal liver failure, they defined it as an INR of more than 2 within the first 30 days of life. Consensus state from the INASL is there, that is acute liver failure in Indian setup is without pre-existing liver disease. That exception we already discussed, with onset of jaundice and coagulopathy, encephalopathy, and duration is 4 weeks for our setup. Regarding the disease burden and etiology, there is no central registry for collection of the data on the ALF in India, and during epidemic of viral hepatitis, this ALF presentation remain 1% in the clinical cases. Coming to the etiology of ALF in India, this is the again article from Indian Journal of Gastroenterology 2024 from S.K. Acharya sir, where they mention that in India 80 to 95% of patients will have a acute viral hepatitis, that is E, non-AE, B is the most predominant cause, followed by drugs 2 to 11%, and among drugs ATT remain the most common cause. Contrary to the Western data, where is the drug remain the most common cause of ALF, the infective causes remain the less. And what about the pediatric acute liver injury? This is again the etiological and the management given by SGPGA article published in Indian Journal of Gastroenterology 2024, where they again mention that in Indian group, again the infective causes remain the most common cause, viral hepatotropic viruses, non-hepatotropic virus plus, and contrary to the developed world, the indeterminate cause where there is the most common in the Western world, where that is 47 to 33% of the patient will have an indeterminate cause, but in Indian set of studies, this cause is very less. Viral hepatitis again remain the most common cause in our setup. And in Indian setup, hepatitis E is the most common that is reported in our all Indian studies, from All Indian Institute of Medical Sciences to SGPGA Chandigarh, from a Sri Kashmir Institute of Medical Sciences. Hepatitis E remain common, followed by A, B and other dual viruses. So consensus statement by INASL is disease burden on ALF, that is ALF is unknown and the exact burden in India is unknown. Hepatic virus are the most common cause of ALF in India. Coming to the hepatitis A, it is a young age and presented as inapparent or subclinical hepatitis, where there is no symptom or jaundice, and in adult it present as a symptomatic in 70% of the patients. Coming to the prevalence of acute liver failure due to hepatitis A in children, these are the group of the studies that is from 1993 to 2015. As we can say, all the prevalence from the initial studies is 37.5, and it is coming down to 8.3%. So over the time, the prevalence of acute liver failure because of hepatitis A, it is coming down. And what about the adult population group? There is a prevalence of acute liver failure from hepatitis A in adult. Similar group of studies, they measure in adult, the prevalence is increasing. Same studies from 1995 to 1.7%. The last study 2015 it is 12.5%. Coming to the hepatitis A, again the further this is again original article published in Indian Journal of Gastroenterology 2024 from SGPGA, where they mention that determinant, profile and outcome of hepatitis A related severe acute liver injury in adults, where they included the total patient of 54 as having a severe hepatitis A related severe acute liver injury, and they divide those patients who develop acute liver failure because of hepatitis A, they check the clinical and the biochemical profile of these patients. And in this study they mentioned that it is all the age, sex, bilirubin level, although there was higher in the acute liver failure group, but they mentioned that the ammonia, baseline ammonia, that is a 229 microgram per ml was high, and they mentioned that this was a significant finding in these kind of patients. So hepatitis A patient group having a baseline ammonia was having 229. These patients were prone to get up from acute liver injury to acute liver failure. This was their conclusion that baseline pneumonia may be an important predictor for progression even in the severe acute liver injury, which mandate a large well-designed studies. In pediatric age group, this is again from ISGTNC Chandigarh. They mentioned that prognostic marker in hepatitis A related pediatric ALF with a validation of a pediatric hepatitis A various prognostic model. We already include this model as a, normally we use a King's College criteria for the prognostication post liver transplant. So in this group, they included the total 96 patients in hepatitis A related pediatric ALF, and in addition to the King's College criteria, they included this pediatric hepatitis A group also, where the three components included, that is INR of more than 3.1, jaundice to encephalopathy onset of more than 10, and hepatic encephalopathy grade 3. And they find that this pediatric hepatitis A prognostic score has scored better than the King's College criteria. We can say the sensitivity of post-liver transplant prognostication was high as compared to the King's College criterion, which was significant. And they concluded this as a pediatric model should be used as a prognostic model for this patient having a hepatitis A related pediatric ALF. So consensus statement on the etiology of hepatitis A is a not uncommon cause of ALF as per INASL, and there is an increasing trend of incidence of ALF in children, adult as compared to the pediatric population. Coming to hepatitis E, hepatitis E remain epidemic in India, and most causes of acute sporadic and epidemic hepatitis. And E-related ALF is all different studies including 15 to 45% of the patient, and genotype 1 remain the most common cause. And mortality is 48.4 to 51.5 in all Indian literatures. Again, this is again group of the studies in Indian studies that shows hepatitis E remains the most common cause in all the patients of acute liver failure. This was the first of the kind study by Professor Kuru, where they first diagnosed the patient of having viral hepatitis in pregnant females, where they included in a related group, that is a similar age female, sex, male, as well as a non-pregnant females. They included that the pregnant female was having a high risk of getting a viral hepatitis E related hepatitis, and among that acute liver failure was high in 8 pregnant failure, which culminated to their fulminant onset and death also. This is again study from All India Institute of Medical Sciences, where they included that hepatitis E and acute liver failure in pregnancy. And again, they mentioned that hepatitis E related ALF remains the most common cause in these kind of group of patients. The etiology remaining most common, that is 59.4 to almost 100% in the other studies also. This is again group of the studies that all over the India, that is showing the prevalence of hepatitis E remain in this pregnancy age group of population, and the trimester is also second to third trimester is the most common factor is there population. Coming to their vertical transmission, these similar studies have mentioned that there is a high chance of getting a vertical transmission also. That's almost 100% patient will transmitted this virus to the children also, and post-term there is a fetal complication also being noted in these patients. This is again study from All India Institute of Medical Sciences, where they include the 20-year experience from this patient regarding the prognosis. So in this study, what they find is that although the pregnant females is having a propensity to get a acute liver failure or acute liver injury, but the mortality remain, although it is not comparable with the, as compared to the non-hepatotropic viruses also. So the chance of getting infection is high, but the mortality remains same. So the consensus statement is on the ALF in pregnancies, pregnant woman is more prone to get a non-pregnant woman. Hepatitis E remains the most common cause, and third trimester is the most common involvement is there. In pregnancy female, we have to rule out acute liver failure, other causes like fatty liver of pregnancy or HELLP syndrome, and the prognosis of ALF in pregnancy is similar in compared to the general population, independent of etiology of ALF or the trimester of the pregnancy. Hepatitis B, it is an intermediate endoscopy in the India, constituting about 2 to 4%. Hepatitis B related ALF is 0.8 to 39% in a different series. And in these all studies, they included the testing is by HBs surface antigen and IgM, and none of the studies have included the quantitative HBV DNA PCR. And issue was remaining in these all studies whether these are the flare of the hepatitis B or there was super infection by the other viruses. This is again group of studies that showing hepatitis B presenting as ALF in Indian setup. So the consensus statement of the INASL is that hepatitis B is an uncommon cause of ALF and possibly decreasing over the time. What about the other indeterminate etiology or other viruses? And in Western world, almost 47% of the patients there will remain no etiological agent is not founded. And this is a study from Rajasthan in Indian Journal of Gastroenterology 2024, where they mentioned the total 63% of the patient who admitted with ALF, almost 50% patients were having a viral infection, but which was not pertaining to the hepatotropic viruses. There was malaria was most common, followed by dengue, leptospirosis and scrub typhus. And they included that patients coming with acute liver failure, features suggestive of viral hepatitis, we have to look for the other causes also, like malaria, dengue, and their prognosis was better than these other hepatotropic viruses. This is a study from Northeast India, where from Assam Medical College, where they almost one third of the patient was having, among the 255 patients, there was almost one third of the patient was having a non-hepatitis A, B, C group infection was there, and again which proven that indeterminate etiology remained the most common cause, that to the underlying viral hepatitis. Most common among that in our Indian setup is the dengue related acute liver failure. There is no much of case reports or review of analysis has been given regarding this liver failure, dengue related, and this was again a narrative review by Kolkata, where they included all the studies till 2023, and they all included the case reports, case series, and studying ALF dengue related was included. And what they found that the incidence of dengue related remained high in the pediatric age group, that is 1.1 to 15.58 patients. Adult was having 0.2 6.6. The risk predictor was age less than 40. There was admission AST ALT elevation more than 1000, and there was admission underlying platelet count was less than 50,000, and the mortality was high in adult group, that is 0 to 80%. Pediatric it was 12.5 to 75%, and the admission determinant was admission pH, serum lactate high, and if there is a presence of underlying cirrhosis, these patients get prone to get a more of a ALF because of the dengue related. Regarding the treatment, they mentioned there is some benefit, but there is a limited evidence of any plasma exchange or a liver transplant in this group of patients. So consensus statement on the etiology of other viruses are again negative etiological workup in our Indian setup is in adult it is 15 to 47% of the patient, in children it is 13 to 20%, and other viruses workup yes we need if there is a clinical scenario that is pertaining to us, like dengue viruses, herpes simplex, Epstein Barr virus or varicella zoster is there. Coming to the drug-induced liver injury, induced acute liver failure, drug remains the most common cause of etiology in higher population, high income countries. As we can say in our Indian setup, it is 2 to 11% pertaining to the Western population, where it is varied from 30 to 70% patient. And there remain the paracetamol is the most common cause of acute liver failure, and in Indian setup it is the ATT that is constituting about 70 to 75% of the patient. So in India, antitubercular treatment drugs related to 70 to 85%, followed by anti-epileptic, first generation sulfonamides and antiretroviral drugs. This is a study again which is from All India Institute of Medical Sciences, where the anti-tubercular drug induced acute liver failure magnitude profile, prognosis and predictor of outcome has been noted. Among the total patients of 1223, there was 5.7% patient was having an ATT induced ALF, and almost 2/3 of the patient the ATT was started empirically. This is again study which shows ATT. There was among total of 269 patients, ALF was diagnosed in 25% of the patient, and there was ATT remain onset of the ATT was 1.9% 9 months, and 75% patient developed within 1 month. And there was a correlation of infection of HIV infection was also in these patients. Regarding the liver transplant data in this patient, a total all study from All India Institute of Medical Sciences, a total patient of 90 patient was included, and among that 7.7% patient was having an ATT induced ALF, and among that 50% again the patient was started ATT empirically. In this study also, this is interestingly they mentioned that the interval between the onset of ATT and development of the jaundice was 6 months or 4 months, as compared to we see that it is a 1.2 months or sometime 2 months. That is not in the intensive phase, that continuation phase also is prone to get patient develop a ALF. Coming to the complementary medicine, this is again study from Sabe Philip from Kerala, published in Indian Journal of Gastroenterology. Among 1440 patients, 2.2 patients was having a suspected this complementary medicine acute liver failure, and there was a subsequent ingestion of arsenic and mercury ingestion that was found within the drugs composition also. Continuing the complementary medicine, this is ashwagandha induced acute liver injury. Again, a case series by same group, Cyrus Abbey Philip. Again, they mentioned that among the 23 patients who admitted, there was almost 5% patient developed ALF, and in these patients, 3 died. So drug remain important diagnosis, and it will remain a diagnosis of exclusion. And DILI, especially in Indian, ATT induced DILI, and that is empirically that is ATT started. That is remain a most common cause, and not it is the intensive phase. We have to continue for the continuation phase. We have to monitor the patient until the continuation phase is over. Coming to the yellow phosphorus, it is again one of the most common cause of acute liver failure in Indian setup, and its toxic dose is 1 milligram per kg per body weight, and it is commonly used as a rat killer, and it is common agent that is used as a suicidal agent in South India especially. This is a world map that is showing where this yellow phosphorus is used as a common agent as the ALF. Coming to this only, after that our TNS, this Society of Tamil Nadu only, they have given this article, rodenticide is mentioned in an important cause of acute hepatotoxicity in Tamil Nadu, southern part of India, where that among the 2022 patients, 261 patients, the abnormal LFT was diagnosed seen in 450 patients, and the rodenticide was the most common cause in this patient, followed by paracetamol, and the other group was also having there. All patient was taken a suicidal intention, and there are almost 1/3 patient died, that is 131 patient died. This is again further on group of studies from Indian setup showing yellow phosphorus induced acute liver failure. The mortality remained very high, 21%. Again, studies 19.5% to 51.5%. Giving to this only yellow phosphorus induced acute liver failure, Liver Transplant Society of Indian guidelines for this management of acute liver failure secondary to yellow phosphorus has given a modified Delphi technique consistent development. In this patient, they included that as these patients are getting a high mortality rate, so early listing of these patients has been very important. And if they follow these criteria, like if there is INR of more than 1.6.0, any MELD of more than 36, persistent lactobacillosis or any encephalopathy, these patients are subjected to early liver transplant. And continuing this yellow phosphorus acute liver injury, this is again study from Chennai, published in Indian Journal of Gastroenterology 2024, where these patients are subjected to for the encephalopathy NCCT head, and simultaneously they included the non-contrast abdomen CT also, that is the liver index also, and they calculated the liver attenuated index. In those patients which develop acute liver failure because of yellow phosphorus, they included that the -30 liver attenuated index was significantly as compared to the -8 liver attenuated index as compared to the other patient, and they proposed that if this acute liver failure patient is getting to get these CT head because of other causes like ruled out encephalopathy, this could be one of the markers that we can study. Regarding the management, Tamil Nadu Society has given itself as a whole management of the rodenticide, which is published in Journal of Gastroenterology, Hepatology and Endoscopy. Consensus statement regarding the etiology and toxin. Toxin is one of the important cause. Yellow phosphorus, especially in South India, is one of the cause of causing the ALF. Vascular cause, Budd-Chiari syndrome, again it is in Indian setup, it is 0.9 to 1% in all case series is mentioned, and the largest series remain from the US only. There is not much of Indian data that I was able to find. This is again the US data where the Budd-Chiari causing acute liver failure, a multicentric case series they included, and in these patients among the 79 patients, they mentioned that the patient who survived the Budd-Chiari syndrome, acute Budd-Chiari syndrome, the survival was having a low AST-ALT ratio, and these patients received anticoagulant at the admissions only. There the survival was better as compared to the other patients. So again, consensus state from the INASL is ALF due to vascular cause remain a very rare cause. Coming to the autoimmune hepatitis remain an indeterminate etiology of ALF, ranging from 8 to 30% of the patient, and most studies have looked at acute severe acute autoimmune hepatitis and ALF related autoimmune hepatitis combined as a single etiology. So they don't differentiate between the whether patient having ALF or not. A patient who developed with a severe injury hepatitis having underlying autoimmune hepatitis, most of the studies included those studies only. This is a study from Mumbai where the natural history and treatment outcome of the severe autoimmune hepatitis has been taken. Among the 101 patients of autoimmune hepatitis from January 2011 to 2015, among that 12.5% developed acute liver injury, 9% were having a severe acute hepatitis, and 50% patients were having an acute liver failure. And regarding the treatment response, 50% responded to the treatment, 25% response partially, and 25% responded failure. So regarding this liver biopsy, yes, in a patient of acute autoimmune hepatitis suspected patient, if there is absent autoantibodies, gamma globulin is low, poor prognosis is noted in this kind of patient if there is an underlying high grade of hepatic encephalopathy, high MELD is there, or there is a lack of improvement within 7 days of corticosteroid, and liver transplant remains one of the important modality for these kind of patients. So in consensus statement from the etiology of autoimmune hepatitis, it is remain one of the most important cause of indeterminate etiology, ALF. 1/3 patient is related to ALF only, and we have to suspect if there is autoimmune antibodies positive, high globulin or other autoantibodies is also present, disease is there. Coming to the Wilsonian ALF, this is again study published in Indian Journal of Gastroenterology, where they compare the ratio of AST-ALT with the total bilirubin to the AST marker as a patient has an acute liver failure prognostication. Among these, the 60 patient, that is including 40 was having Wilsonian ALF and 20% patient were having a non-Wilsonian ALF. They included in a Wilsonian ALF, the consanguinity was 32.5% patient were having, KF ring was present in 72.5 of this patient, mean ceruloplasmin was lower in this group of patient, and the AST ratio was high. And when they taken this as a cutoff more than 1.85, the sensitivity of diagnosis of ALF because of Wilson disease was 77.5 and specificity was 95%. And the ratio of ALP to the total bilirubin less than 4, the sensitivity of 32.8 and specificity of 100 with a positive predictive value of 100 with negative predictive value of 42.5. And the mortality was remain high in the Wilsonian age group. They concluded that although this positive AST-ALT is a strong predictor of diagnosis of Wilsonian ALF, but the negative result does not preclude this diagnosis of Wilson disease. And we can't use these ratios as a diagnostic tool for diagnosis of Wilsonian ALF. In addition to that, the Coombs, Yasser also mentioned, the Coombs negative hemolytic anemia is again important predictor of diagnosis of this patient of Wilsonian ALF. Other causes, HLH, Rees syndrome, extensive malignant filtration is rare in ALF. Role of histopathology, as we already know, there is not much of a role of histopathology mentioned in acute liver failure. This was the review article, this is the original article published in Indian Journal of Gastroenterology. We have taken the 5-year retrospective study regarding the acute liver failure histopathology. And among the 182 explant, 22 patients of acute liver failure they included, and they categorized these patients into 6 pattern of hepatitis on the basis of histopathology. First one is the panlobular involvement, diffuse involvement. Second one is the panlobular. Third one is the bridging. Fourth one is the zonal, and fifth one is the azonal. Except the etiology of autoimmune hepatitis, where they find the lymphoplasmacytic infiltration, rest none of the pattern was any etiological specific. So there was a etiological overlap was also there. So they included there is a morphological overlap, but in autoimmune hepatitis ALF there was able to diagnose because there is a portal plasma cell infiltration and there was centrally penetrating involvement was also there. Coming to the diagnostic worker, there is a battery of tests that we have to go for these kind of patients. That's included diagnosis of ALF, and simultaneously we have to investigate for the infections and the monitoring. Coming to the viral hepatitis group, we have to do all these investigation, HBV DNA, if there is underlying, we are suspecting a hepatitis B group. Tropical infection, very common if there is a pertaining setup. Leptospirosis again very important. Extended viral marker only if we are not able to find the underlying etiology cause, and clinical there are other features also there. Again, to rule out ischemic hepatitis, echocardiogram we have to do. Again, autoimmune etiological workup we have to do. Wilsonian, if patient is having this criteria, ALP, total bilirubin less than 4, and if there is a toxin suspected, we have to go for toxin screening. Coming to the management, liver transplant, as we all know, it is remains one of the important cause. Modality remains the treatment of choice. And this is a study published in Amrita, in again Journal of Clinical and Experimental Hepatology, where they taken the 10-year data from the Amrita Institute from Kochi. Among the 332 patients, only the 70 patient was fitting into those who after exclusion of criteria, there was a financial constraint, there was unwillingness, and there was a lack of donor. Most of the patients are already expired. 70% of the patient they underwent liver transplant, and the live donor was having 69 and dead donor was having a 1% patient. Demographic etiology of these patients was having, again the age of more than 12 was 87.1% of these patients. So, ratio was male female was having same, and the etiology in these patient group having a seronegative was almost 1/3 of the patient. Yellow phosphorus again 22.9, and hepatitis A is the 21.79. Rest of the hepatitis E, 88 induced autoimmune was other causes. And interestingly, there was a mortality almost in the 38.6 patient, almost 1 to 2/3 of the patient died, and the mortality was within 90 days, but there was very high. And the cause of the mortality remained sepsis with multi-organ failure and cerebral edema. This is the analysis of mortality in this group of patients, where they find that again hepatitis A patient having a ALF was having a high mortality, followed by yellow phosphorus and seronegativity. This is again medical management given as a role of N-acetylcysteine and acute liver failure, where their patient was not mortality for any acute liver transplant is not available. Where they given to every patient like hepatitis E, A, drug-induced patient were having this N-acetylcysteine is given, but as we already know, only expect the drug, the rest of the treatment not worked out. Coming to the plasmapheresis, this is the study from ILBS Delhi, where they encountered the standard plasma volume exchange improved the outcome of acute liver failure, which was not prone to get a liver transplant. Among the 126 patients, they standardized into 20 patients received the standard medical treatment and 20 received the standard volume plasma exchange. And those patients who received the standard plasma exchange, their 21-day transplant survival was very high. Coming to the last one is the plasma exchange group. Again, this was a systemic review analysis given in Indian Journal of Gastroenterology from CMC Vellore, where they included all the studies, that is our Indian setup, 8 studies with a plex of 284 patients was given, RCT was 2 included, and cohort study of 6 included, with a comparing with a single etiology. And they find out that in all the mortality less than 60 days, the plasmapheresis favored the diagnosis, like survival rate. Less than 60 days also favored the survival, less than 90 days it also favored the survival. And coming to the last group is the single base etiology, drug etiology, it again the favored the etiology. And they concluded that plex is a safe and improved survival and independent of the volume utilized. That is, high volume or low volume doesn't matter, the plasma remain an important viable cause. And this group, this survival benefit was high in the single etiological group. Again, last is the extracorporeal liver transplant therapies. In addition to the plasma exchange, CRRT, plex, CRRT and MARS. Again, this is a scientific review analysis by CMC Vellore. They mentioned that all the patients who received plasmapheresis, their survival as compared to the standard medical treatment is better as compared to the patient who did not receive the treatment. At the last this acute liver failure management remain a multimodality treatment. It is a part of hepatologist, intensive and transplant surgery. Among that, neurologist, neurosurgeon remain is there. Nephrology, and it remain a holistic approach to the management of liver failure. These are my references. And happy Good Purnima to all my teachers.
That was an extensive research you made, and that's a very good presentation. Thank you, Dr. Swapna. And it's open for discussion. If there is no open discussion, I'll hand over the mic to the secretary.
Thank you, chairpersons. It was a very nice evening monthly session as well. So, ongoing multi-center study, we are still collecting plex data for ACLF and ALF. I think there's probably one more month to go. So, I hope all the centers will be able to collect and collect the data to bring out as a presentation, as a publication. The key forthcoming meetings, please note the dates. The Tamil Nadu ISG midterm meeting will be on October 19th and 20th at Kutralam. Please make your travel arrangements. We have limited train services to them. So the organizing team headed by Dr. Kandasamy is already preparing an academic program. Hopefully we'll be getting out the flyers and the early program schedule shortly. And the annual meeting will be on February 22nd and 23rd of 2025 at Coimbatore. We'll be working on it shortly. And the INSL is coming up next month. Now is 7th and 10th at Cochin. And the ISGCon national meeting is on December 4th to 7th at Varanasi. So I think July 31st is still the last date for submitting your interesting case studies, clinics in gastroenterology, endoscopy. So at least another 2-3 days are still available for you to upload your interesting cases. So in this year's yearly meeting, we did discuss about the Tamil Nadu ISG Postgraduate Travel Fellowship. I think we have an expert selection committee which has been constituted. We requested Dr. Jayanti, Dr. Ramakrishna, Dr. Venkatakrishnan, Dr. Ethan, Dr. Ramasubramanian and Dr. Prem Kumar to be part of the committee, and they have consented to that. They will lay down the rules and regulations for the selection, how many candidates and how to go about. The details are being worked on and we will be coming out with the details shortly. So again, please take a minute of yours to fill in up your Tamil Nadu attendance through your QR code that has been given to you at the entrance. So that will help us submit it for the Tamil Nadu Medical Council points. We have an international meeting coming up in 2025 to be held at Chennai in association with GEM Hospital. I'll request Dr. Vinod to come up and brief us about that meeting, please.
Good evening all. First of all, I'd like to thank TNISG, Prem sir, Prama sir and Adul sir for giving this opportunity. The reason behind this is we all know we haven't had a big international sort of meeting in the past 10 years in Chennai. When I spoke to KRP sir, I think in Indocon, sir, we have to do something and probably I'll ask GEM Hospital and you be the guide to us. He immediately said we are there and please conduct and we are there with you to help you. So I'm really thankful for the patrons for this meeting, KRP sir, and I also spoke to TSC sir and Ravi sir for guiding us, and please guide us in each and every aspect, sir. This time I'll take the opportunity. We have prepared a trailer for this international meeting, and I feel this is a very good platform and it's better to launch here first time. So I request Dr. KRP sir to come and launch the trailer for this upcoming international meeting termed as Scope 2025.
Scope 2025 at Chennai ITC Chola. This is an international event where eminent faculties from all over the world are coming. Some of them are innovators. This is organized by a medical team headed by Vinod. And this program going to include live demonstrations, endoscopy procedures, debates and keynote lectures. And video contest is there. You all can send videos for participate and avail attractive prizes. And beginners can take part in the basic training programs and they also get opportunities. This is a very important attractive program in the entire country where everyone can have benefit participate in it and carry good messages. This Scope 2025 is an international event going to be held in Chennai. This event is going to be on 31st May and June 1st. So thank you very much. I invite all of you and see you at Chennai.
Chennai, a city of culture, heritage, famous for its temples and architectural designs. With unique foods and flavors. Also known for its top-class medical care and medical tourism. GEM Hospital is a leading gastroenterology care center in South Asia, founded by Dr. C. Polinivil, who does not need any introduction, under his leadership and guidance from our patrons. Our medical gastro team, along with TNISG, is organizing. We have a galaxy of stars. Interesting sessions like Interact with the Innovators. Keynote lectures by stalwarts. Debates by doyens. 8 hours of live endoscopy. Video contest with exciting prizes. Full day technician training program. See you in 2025.
And Dr. Palnivelu for the effort in organizing this important international event. The last one which we held was in 2014, it was the World Congress on the US. And even before that, we never had any big international event on endoscopy in Chennai. I was really telling our colleagues, even the SGI conference, we never held it here. I think you should plan one SGI later also. With that, I would like to convey my best wishes for the success of the meeting.
The next part of the program will be a CME part, where I request the chairpersons, Dr. Palaniswamy and Dr. Jayanti, both senior faculty in Tamil Nadu ISG, to conduct the proceedings, please. I request.
I am very happy to chair this interesting session where Dr. Malay is going to talk to us on how to do research and publish MS busy clinical practice. I think this today is very important. I would like to briefly introduce Dr. Malay, and most of you are familiar with Dr. Malay, and he has been a good friend for decades. And in fact, I observed Dr. Malay in close quarters, and I've had an opportunity to visit his center in Meerut, where he held the US international meetings, and which was held in air-conditioned tent, and which was well attended. And from then, he has moved on. Of course, he has held, I think, several of us, our colleagues, at training in advanced endoscopy and US from his center. And many of our colleagues are amongst us. They are doing an excellent work. I think Vinod was a trainee with you, that's what I remember. And then from there, not only that, from there he has progressed from training people to research, publication, and also publishing a book on US anatomy. Really, I'm very happy to be the chairperson here. I would like to hand over the mic to Dr. Jayanti to introduce the topic.
Welcome, Dr. Malay. It's nice seeing you here. I thought probably you were online. I didn't realize there was a US session going on. So Malay is an alumnus of CMC Vellore. We have known him since then. And I think the important topic, I think, Malay, I asked you for the gallbladder bile and the stones from Meerut to study the gallstones in South India. So I think most of the PGs who joined him for the various training programs were incorporated, and they had to do and publish a paper during their tenure. So many of my PGs who were with you during that time when you were training them for endoscopy, they did have some publications. So over to you, and let's hear from you.
Yeah. This is a strange topic and I didn't know how to address it, how to do research in a BD practice. So a little bit of theory, philosophy will go a long way in saying it in an emotional level. But why do it? Why do the research? You become successful, you have passed your degree, you have passed your exam, you are busy in practice, and you are already earning roti, kapda, makan, you have got everything in your life. You have got, why do research? So though this thing is published or perishes, more for people who are in government institute or fighting. But then the dil mange more means that we want more from life, and that is where the story starts. So you have to have a warmth in your mind. There is a warmth. You have to feel different from others. And the research warmth. And the research warmth has to be strong enough to tickle you, to stimulate you, that you have to do the real research. But then you are lost. Why do the research? Satisfies your ego, it makes you feel different, it will make you powerful, yeah. Even I exist. I think, therefore I exist. And these are the reasons that you want to do research. But remember, research is a very lonely pursuit. There is not easy to find a person to help you. So before you embark on this path, before you go on this lonely path, remember, very lonely. Because this lonely pursuit, when I was earlier days, we would look at a researcher as a person who are crazy fellow. Everybody, a crazy fellow. He is his ideology, he wants to do something, we call him a stupid fool. Not here, everywhere in the world. All these researchers are called as crazy fellows, and they are pursuing a cause till the end of their life. Miserable, sometimes cash crunch life is what. But the times have changed, and that is where we have to find that route to research. A busy man has time for everything, and there are many quotes, but I will try to make my point that research is a door to which you have to find the key, and this is a veil which will lift in front of your eyes. So theoretically, philosophically, this is the way of life. The problem is you have to find a mentor. It must, and once you find a mentor, then you have to be like the mentor. But it is not must. You can be your own mentor. You can make your own destiny if you want to do research. So the research will be either through the mentor or through the self-style. And you will be either good, bad or ugly as a research person. A research person is not always good. There are bad and ugly. So no, beware of what you want. You want to be a researcher? You want to be a researcher? But you can be either one of the three. What is a good? A good shares, that is the only thing. A good shares, whatever he knows, everybody knows. He is not scared of sharing. The good one shares. And he shares everything. He doesn't hide any trick. He's in fact want to tell everything. He's eager to tell everything. And this is the only definition of God. And a good test, he doesn't say, I am the God, I have found the truth. I have found a truth. And the good tells you to ask these 5 questions. There is a problem. Who cares for this problem? Why? What have others done to as a solution to the problem, and what is my solution? And is this solution a good solution to the problem? But what is the bad and ugly side of it? Before I embark on this path of the research, I have to find there the bad and ugly. Research is cash cow, big money, big money. People are hungry. They are crazy, crooked research, and they sell false dreams to their students, to their followers, to everyone, and to companies, and the drug companies selling research to us, and researchers selling dreams to company, and then there are backing of laws, ethics. So, this, as I said, what is the law? We are delighted in making laws, but we are even more delighted when we break the laws that should be fundamentally making the laws of research. So, a comparison, the good and the bad and ugly, a good cares, the bad invents a problem sometimes. There is no problem. But the bad invents a problem and then creates for solution for that problem and then shows that only God or me would have given this solution for the so-called problem that has been invented in any disease, whether it is IBD, IBS or liver. So real research, dear friends, is a simple twist and tail, and it is a real twist. But if it is a created twist, then this is a false research. And as I just said, that the researchers are making guidelines, and where they are making by guidelines? Who are making guidelines? They are making guidelines in hotels, 5-star hotels, relaxing, and that is where, dear friends, when apathy hits people like you and me, these are the people who think they are the best, they are my alma mater, they are the God. And when I see them making, these are the guidelines, which are guidelines have been formed by whom? Making guidelines. Does he know enough about making the guidelines? And he is telling me what to do. We don't know which part is right, which part is wrong. Sometimes we know what is right, what is wrong. So maybe I have said too much, but this is the fact. Before you join me and many others on this bandwagon, where these are the bandwagons, that this is the path of research that we have to bandwagon. And we decide, is Indian research reliable? Or is Western research better? Okay. Which research is falsified? Where is the corruption? Are we part of this corruption? And can anybody supervise research? Is there an ethical committee? And who is making the ethical committee? And once I made all this question, I believe in your own heart, many of you would have answered the preliminary question. I want to get married to research. It is going to be my second wife. Now I have to look for a mentor. I have to look for a suitable mentor, suitable Brahmin, which in old days will get you married to your second wife. So Guru, how to go to mentor and Guru. So how will you find your mentor? You will be either a self-styled Guru, self-styled researcher, or the question is, if today in this audience a person cannot identify a Guru, he is not fit for research. So you know, your heart knows, your mind knows, And second thing is, if you do not respect a researcher, you have to respect a person who is doing research. Whatever said and done. But if you cannot respect a true researcher, you have to identify the good, bad and ugly. And once you have identified the good, then respect. And then you will be able to do research. Without that respect, you cannot do it. And now I come to my journey in the research. And this research started in Meerut. My professor G.P. Alliance went to Vellore, Dr. Ashok Chakbo. And though through Dr. Jayanti, indirectly, I was not her student at the time, but through her student, Rajesh Prabhu came back to me, the most important of all, gastroenterologist in Apollo, and then my daughter and my wife, how they played a role in this my journey of research. I entered into medical school, so this is my first exposure to research, that I was given a project in anatomy. Copy this music, make something new, new project, new diagram, new thing. So this was the research in medical college. MD, days 1984 to 86, my professors told me, frankly, I'm sorry, I didn't know, but I tried. I tried in diabetics to separate lymphocyte T and B lymphocytes. I did a job, but I didn't understand what was happening. My thesis was published. I published malabsorption in cirrhosis in CMC Vellore, but I admit it today that even then, even though I identified some malabsorption in cirrhosis, today, after 30 years, I have no shame in admitting which journal was my paper published in gut. So, here on, then Dr. Jayanti came. 1990, we thought she belonged to a different planet because every month she was appearing in gut, writing the article. The first page in the gut we were seeing, and it was Dr. Jayanti, this. And there were a lot of stories circulating in the corridors of CMC Vellore, what she has done to publish those articles, what she gone to England. And I believe most of you would be knowing these stories. And though she was the motivating factor, but as I concede here today that we all thought she belonged to a different planet, and that is why we never tried to emulate her, and I never tried to emulate her, and I kept on my own shell. However, in 1992, I tried to enter common bile duct. I was able to start ERCP in my career in 1983. Say, in 1987, and 6 years down the line, I tried this. No, 91, I started practice in 91, and I put a stent into pancreatic duct with an intention to block it so that the wire does not go into the pancreatic duct. I succeeded in inflation, but I was scared, nothing happened. And years later I found out that I did the right thing. But I made the mistake of not publishing it. I told a couple of my colleagues that if you are failing in ERCP, block the pancreatic duct by placing a stent and then try. And many of them succeeded. And I don't know today who published first that you should place a pancreatic stent if you cannot get into it. Okay. Then came 1998, a case of total biliopathy. Many big people have failed in that. Removing the big stone impacted. And the patient was having recurrent cholangitis, bleeding. Whenever somebody tried to remove, there was bleeding. And they will give up. Put in a stent again, send the patient home. I was relatively free those days, not so busy. And I was mentally challenged. Even I exist. That was the thought. I exist. Big stalwarts, big people in field. So I just took the challenge. I arranged 5-6 bottles of blood, gave him octreotide, and I started, okay. First cannulation, the patient started bleeding. I kept on transfusing, kept on putting the water. Then attained bleeding will stop, again some blood will come, I will wash. I had learned to wash liberally, keep on washing. My assistant told me blood pressure has dropped 80. Let me remove 2 more fragments and then I will leave the procedure. To my dismay, as my basket caught a big one. And then I had to use a Sohindra electroprotector. The blood pressure dropped further to 70. I said, fluid, hemosil, all those. But breaking the stone took 15 minutes. And then I realized, no bleeding, I am able to do it. And then I found out that the drop in blood pressure was helping me in clearing out the stones. So I started transfusion, said okay, let it be 80-90, and I kept on trying repeatedly, and after 4 hours and 6 bottles of blood transfusion, the whole stone was removed. I kept on waiting, transfusing, but I allowed the blood pressure to remain at 80-40, and the stone was free from its life. So this we published later, much later. Nitroglycerin-induced hypotension or management of portal biliopathy, because it clears the stone. Otherwise, for the rest of the life, you keep on putting stent, metal stent, multiple stent, keep on sending that. Induce hypotension, do the job. So 2000, what happened? I thought of buying research again. So my daughter was given a project in geography. She was in Valamsi school, Dehradun. I saw the miserable place. That everybody is buying projects. But then I realized, no, I cannot do it. I have to start and make. So we make the long project. I helped her, she made the project, and that transformed me. 2002, Rajesh Prabhu came along. We worked together for some time. So he noticed that when we were removing an inflated balloon, lower end, in case of portal biliopathy, there was a lot of bleeding. And then he pointed out that we are probably bringing out the squeezed varices to the lower end. So we must deflate the balloon first, because the stone have already been brought to the lower end. Allow the varix to become free, re-inflate and then remove it. And this we published. And that was my first research publication. All courtesy to the brilliant person, Rajesh Prabhu. But he started me on a path. 5 years down the line, I did a couple of publications, and 2007 I did endoscopic ultrasound, and when it came, I had no way what to do. But I started publishing Doppler signal, first on aorta, then on portal vein, then on the branches of aorta, first order, second order, third order, and then on the tributaries of portal vein, and then on anechoic structure. Frankly, way back at that time, 2005, 7, there was no way, not many books, no literature available to how to do. So the only thing I had available was a color Doppler and follow the vessels. And what followed was I read CT of peritoneal cavity, CT of peritoneal ligament, ultrasound of ligament, CT of liver segment, CT of aorta and its branches, CT scan of organs. Then I read the anterior posterior surface of anatomy, CT of, and then I started understanding how to do ultrasound of organ, endoscopic ultrasound of organ, so CT ultrasound, applied anatomy, and then it all came together. So there were a lot of first, and there were so many lot of first cases report, though my colleagues thought that I was mad because I was publishing a lot of, you don't have to do endoscopic ultrasound, but in almost every bleeder I was putting in endoscopic ultrasound scope and was able to find hemosuccus pancreaticus, hemobilia, lot of aneurysm, aneurysm, and vascular endoscopic ultrasound became a favorite topic to me. I started. So the story is that I became a vascular endosonographer and I learned my most of endoscopic ultrasound through application of vascular endoscopic ultrasound. Coming to the last part of the few slides, so despite all controversy, research will continue. And will continue initially as case reports, maybe case series, for people who are busy in their private practice. They have to find something is new, something is different, and they have to report it. I was lucky because I was able to find a new niche of endoscopic ultrasound as a technique which I could work on. A modality, a fresh modality in practice. And I could work on that modality. Maybe tomorrow there will be something like endoscopic MRI or something, whatever comes. And those things, when they come, there will be new technology and all this, and many of you will find. I can tell you there are many people in India. Somebody has said that early gastric cancer is as common in India as any other part, and more common than Japan. I don't know whether that is true or not, but maybe there will be new, more exciting things. So I can say I was lucky. So how to do it, how to go about the research now. I will say I cannot make a give you, any of you, a tailor-made path. Each person has to find his own destiny. Like Dr. Jayanti did as our mentor, was my mentor, and in the corridors of, I believe, in Lucknow, in London, in some library, or as many of you did, as I did, I stumbled through one of our students on the pathway of research. And case report, you have to publish if there is a twist in the tail, because everybody is interested in twist, but do not deliberately twist. Research starts with case reports. You have to have the enthusiasm, There are many people who have seen many different kind of cases, but please publish them. Do not be a flower which will blush without being seen. Full many flowers are born to blush and see. You need motivation, you need support, you need to observe, you need to see. You need enthusiasm, you need a place to report, you need a way to report. You have to be melodramatic, you have to be simple, you have to pursue a dream. And you have to dream has to make an impact on some part of management, some impact. You have to follow small journal, bigger journal, smaller journal. You have to follow and get it published to the finish. And you do not have to get rejected. You have to have a high frustration index. And be deaf if you want to do research as a busy practitioner. This is the story of the deaf frog who listened to none. And he was able to climb the competition onto the highest cliff. Be deaf to negative thoughts. That is how you can do it. So thank you. And in the last part, I am now the Secretary of the Governing Council of SGI. And I would request that I have been arranging an election in Uttar Pradesh of Governing Council of UPSGI. Somehow, when we organize a national workshop, we will need a state governing council, which will allow a person to represent the state governing council in the meeting that we want the next endoscopy workshop, next endocon to be done in our state. So I will request all of you who are present here as Tamil Nadu ISG members to make a chapter of SGEI Tamil Nadu. I have the list. I will make you all a WhatsApp member of that list, and I will formally request an announcement on WhatsApp rather than making it a long process. An election, a selection of president, secretary, joint secretary, and 3 members of the governing council, and you should then work in an autonomous way so that we can grow the society. Thank you very much.
Thank you, Dr. Malay, for a wonderful talk. I'm sure your talk would kindle the interest of many of our postgraduates here. Any questions? Any of you who want to start research work?
I think research is possible even for a busy practitioner. I think probably I would like to quote an example of our ISC member, Dr. Amara Paraka. He was a very busy practitioner in Mumbai, but he has published the original publication, even now it's quoted. I think like that, many of our ISC members, with their busy practice, they continue to publish. I think I keep telling my students, my junior colleagues, please document what you see and then look back and see what you can do. I think we should do it. That's what I've been telling my students and also colleagues.
Once the story goes, I was gastroenterology for about 6 months. In every issue, we had 1 or 2 publications. So some senior person, have you purchased the editor of gastroenterology? But these are all case reports. But I think whatever you can do, you please do, you must publish. Thank you very much.
Thank you very much. We can move on to the next session. Prem and we move on to the next session. This is a panel discussion on approach to pancreatic and liver SOL. I don't know whether it's getting focused to one of the 2 organs or both.
One after that.
Yeah, with 15 minutes each. And so the moderators for this session are Dr. Mukundan, Associate Professor, Department of Medical Gastroenterology, PSG, and Dr. Santosh Kumar, Associate Professor, Department of Hepatology, CMC. We now call upon our panelists, Dr. Prem Kumar, Dr. Vikram, welcome sir, from ILBS, Dr. Prakash Zakaria, nice to meet you here sir, from Lissi Hospital, Ernakulam, Dr. Gautam Krishnamurthy, Surgical Gastroenterologist from Kaveri, Dr. Karthikeyan, Department of Radiology, SIMS Hospital, and Dr. Shirley, Department of Pathology, Adyar Cancer Center. Over to the moderators. One of you can just start off, please.
Much ado, I thank TNISG and Dr. Vishnu for giving me this opportunity. So I'll be discussing a liver SOL. History is about a 42-year-old man from Guntur, Andhra, who presented to us with a history of 8 months of abdomen distension, which is out of proportion to pedal edema, and loss of weight of 15 kilos and loss of appetite. He also had cough without any expectoration. He had no fever, no jaundice, no GI bleed, no encephalopathy, and no dyspnea, though he had cough. A significant history of diabetes for 15 years and past history of lateral pancreatic jejunostomy done for chronic pancreatitis, following which he stopped alcohol consumption. Before that he was a regular alcohol consumer. Examination, he had pedal edema, there was no JVP, vital signs were stable, he had shifting dullness with no palpable organomegaly, and there was right-sided hemithorax, decreased breath sounds. So just summarizing the positive history and examination findings, he had ascites pedal edema with right-sided pleural effusion, loss of weight, loss of appetite, significant past history of alcohol consumption with past chronic pancreatitis and diabetes. If I could ask Dr. Vikram, sir, at this point in time, what would your clinical differentials be?
So, as I see it here, it's a 42-year-old diabetic person with significant alcohol use and chronic pancreatitis who has developed a painless ascites with some weight loss for 8 months and without any jaundice or any acute injury. So, now the differentials would possibly remain two. One, that is cirrhosis has decompensated and now it's a chronic decompensation without any evident acute insult. And this can be a manifestation of a chronic progression of the underlying liver disease. So it's run-of-the-mill chronic decompensation of a cirrhosis with chronic pancreatitis unrelated. But then when we see such cases, we have to see what has caused the liver decompensation. Maybe it is a portal vein thrombosis, maybe it is an HCC which has superimposed, or the ascites, which is the event here as I see of interest, can be related to the pancreas, which would mean a pancreatic ascites. But I would keep it lower down because that is less common and nothing new or significant or clinically evident has happened to the pancreas for a duct to be disrupted. So my take here is first a chronic decompensation of cirrhosis, a cirrhosis because of alcohol and metabolic reasons, and the nomenclature evolves. Second is ascites because of pancreatic ductal injury. And third, obviously, we have to consider malignancy, but the ascites has been going on for 8 months despite weight loss, and malignant ascites without pain, without a primary being evident this long, would be clinically less common.
Thank you, sir. I think we were also thinking along the same lines. We thought decompensated chronic liver disease with a pleural effusion, maybe hepatic hydrothorax, but we were unable to explain a significant 15 kg weight loss with that differential.
So just thinking, can it be chronic pancreatitis with secondaries in the liver, or chronic pancreatitis going in for malignancy, which is known to occur despite the...
So we consider it, he has been a smoker, alcoholic, but then the duration is now, we are wiser in retrospect, it's been 8 months, and a metastatic carcinoma pancreas not being evident on its own for 8 months would be slightly unusual without any pain or that manifestation. Let's say if it was a shorter history, then maybe more, yes.
I'd also consider possibility of is a diabetic, is an alcohol use disorder, so possibility of a tuberculosis, because that is also something which can happen. He has got a right pleural effusion, ascites. So that is also something which we'll have to keep in mind. And no other stigmata, no jaundice or anything else.
Yes, sir. So that was our second differential also, disseminated tuberculosis, maybe pleural and peritoneal. And last, as we discussed, maybe pancreatic or liver malignancy or unrelated lymphoma, which could affect both sides of the diaphragm. His initial investigations, he had anemia. I'll just go through positive investigation. He had a PTNI which was slightly elevated with direct hyperbilirubinemia with a significant age reversal. His globulins were 8.4 and albumin which was 2. And AST LD levels which are normal and alkaline phosphatase that was elevated. His viral markers for B and C were negative. Because of age reversal, we looked for electrophoresis that was not showing any M band. His AH profile was negative. Because of a significant elevation of total IgG, we also looked for IgG4, which was elevated. This was X-ray. Massive right-sided pleural effusion, maybe a bit rotated X-ray. Can't appreciate much of mediastinal shift in this particular X-ray film. When we analyzed the pleural and ascitic fluid, we found that pleural fluid protein was 1.6, the SAG was also 1.6, the cell counts were not too high. The pleural fluid analysis showed a significant protein of 7.9 with a low albumin, and the SPAG serum to pleural fluid albumin gradient was 0.7, LDH was high, and the pleural fluid is predominantly neutrophilic, 95% with a very high 7,800 counts with a low glucose level but a normal pH, and the bacterial and MGL expert culture were negative. And the cytology both for from the pleural and ascitic fluid were negative for malignant cells. Could I request Dr. Prem for his comments on the investigations and what his take currently is?
See, basically, patient has got age reversal, and according to the report, there is elevated alkaline phosphatase and then hyperbilirubinemia, predominantly direct hyperbilirubinemia. When it came to ascetical analysis, SAG more than 1, and of course LDH is elevated, ADA is elevated. So possibility, because he's got a background of alcohol consumption for a long time. So DCLD based on the common DCLD based on the high SAG and other things. But I would like to think other infections also, because ADA is elevated in acetic fluid, and then LDH is elevated. In the pleural fluid, the lymphocytes are more than 85 to 90%. So DCLD background and probably a superadded infantile records, that's already discussed, could be a possibility. Then elevated ALK also more towards an infection, but probably imaging will help us to find out what's the reason for that. Because direct hyperbilirubinemia, elevated ALK, imaging will help us to proceed further.
Thanks, sir. So,
can I just, few things. One is he has probably chronic liver disease, but his platelet count is normal. So that is something which we expect as thrombocytopenia, but the platelet count is normal. He has got a predominantly, a lefty alteration with the cholestatic type of alkaline phosphatase elevator. But there is no cholestatic symptoms or anything. So ascites is the same, as for a pleural effusion, it's high LDH, and though the SAG is 1.6, there's a predominant lymphocyte predominant, but I don't know whether he has been on a diuretic or anything, but that would have been the other possibility is whether it's an infiltrated disorder, the liver itself, whether there is some infiltration which has caused this high alkaline phosphatase with bilirubin level, and probably there is some amount of portal hypertension, but I cannot explain the the platelet count which is normal, which is.
I totally agree, sir. So the age reversal we are taught maybe because of liver disease or chronic infection, inflammation or malignancy. Massive pleural effusion, because it was exudative, we were working up for malignancy and infection. And high SAG, low protein ascites, like sir pointed out, it was lymphocyte predominant, so we thought it was possibly portal hypertension, plus minus secondary infection, but a secondary infection should have caused the protein to go up, which did not happen in this particular patient. Because of the direct hyperbilirubinemia with raised alphas, we wanted to rule out obstruction before we pursue further. And when we calculated the MEL score and other things, his MEL was 16 and CTP score of 10 with child C status.
Can I make a query here? So
yes.
The ascites obviously was high SAG, but you have mentioned the pleural effusion as exudative. Now we know that the protein in general in the pleural fluid is a gram higher than what you have in the ascitic fluid. And then I think we should be classifying pleural effusion exudation not by SPAG but by Light's criteria, which is the ratio of protein in the serum and the fluid and the LDH ratio. So the SPAG has never, to my knowledge, I may be wrong, validated in this. And it is difficult for me to decide a high SAG ascites here and a exudate above. So that if we go by this way, we'll likely overdiagnose tuberculosis. And just
Thanks for your comment. So could I ask Dr. Karthikeyan now for imaging? So we have a CT. I'll go through other images. First, shall we start with CT?
Before I go into the case, I think quite a lot of students are there. I'll just tell you our approach as radiologists. We have come a long way from interpreting shadows. So today, when we
So it's not showing because I think the LED is screen.
I'll just come there. So essentially what we today, how we interpret is first we go through the history. So we have had an elaborate history and we have come to some clinical conclusions. So there are definite indication for what I have to see in the imaging. So what we see is one, radiology is altered anatomy and you look at possible pathology and you glean additional information if it is there from the enhancement kinetics. even though because of the light you are not able to see. Is it possible to switch off one light? Because at the end of the day, these are the ones which are crux, which will kind of give you a path. So this is an arterial phase imaging because aorta is bright, minimal pleural portal vein is opacified, and you see the artery here. So in an arterial phase, what you are seeing is the tumor is enhancing the soft tissue. What you are seeing there is enhancing. And also note, when you come to the venous phase, still the rind is enhancing and there is some retraction with central areas of hypodensity, which also shows some amount of vascularity there. So the simple thumb rule what we use is 80% of the times common ones will be commoner. So the thumb rule what we use is arterial phase hyper, venous phase hypo, which means in venous phase the contrast is washed out. So whenever this pattern is seen, it indicates a malignancy because of the AV shunt. So here what you are seeing, arterial phase is there, venous phase also it is slightly hyper. So hyper, hyper, in delayed also hyper, basically means contrast is accumulating. So when you understand the matrix, what it shows is a fibrotic matrix. So anything which is having a fibrosis will show arterial phase enhancement persisting into venous phase and delayed phase. This is one of the reasons why you have to, whenever you image liver or for that matter today any abdomen, we do a triphasic study. So it's basically quadriphasic if you include a plain scan. Plain scan is mandatory to look at any calcifications or not. So between the morphology and the enhancement, what you have seen is the liver morphology is altered, the parenchyma is looking heterogeneous, and the lesion what you are seeing is showing a characteristic of predominantly fibrosis. The advantage between, it varies from place to place where you practice. Some people prefer MRI after the ultrasound, but for practical purposes I think the best way to do is always do a triphasic CT. The false positive, false negative with CT is less, but we always use MRI to further characterize. MRI helps us kind of problem solving, so we'll go to the MRI which they have done now.
Yes.
Yes. There is a capsular retraction in the both the which is well seen in the venous field. So MRI, what advantage it has over CT is it gives you some amount of physiological and based on the signal changes you can judge. So normally fluid will be bright in T2. So here in T1 normally fluid will be iso or little bright. So the first thing which strikes you is this pleural effusion is T1 bright. So anything which is T1 bright can contain large amounts of protein or it could be hemorrhage. The second thing about the lesion, if you see, we call this isodense. In T1 it is hypotense. Any lesion which is bright in T1 will be either hemorrhage or fat. So there is no fat or no hemorrhage. So now you come to T2. General thumb rule is any lesion which has necrosis or which has a very high malignant potential is always very bright in T2. So if you see this T2, it is not very bright. So anything which is dark in T1 and also in T2, again it indicates to an element of fibrosis. You are dealing with some kind of desmoplastic fibrous reaction.
Should I change that?
So again in the contrast study, the same kinetic characteristics what you saw in the CT. Arterial phase, much better seen in MRI. Again in the venous phase. The second one what you should see is there is not much of distortion of the vasculature within the lesion. So that again is a pointer towards a non-encasing or a non-infiltrative lesion. So based on these two, finally they have done PET. So PET again shows an intense uptake and there is some non-specific uptake in the spine. So essentially when you here, because we are the time is a constraint, we have not gone through all the slides, but typically by the time you do PET, you should know about the peritoneum, you should know about the nodal status, you should know about the metastasis in other areas. one of the advantages of PET, how we use it is we don't need PET for the actual diagnosis. PET is showing an uptake, you already know we are dealing with a fibrotic lesion. The advantage of PET is sometimes it may give small nodes in areas which are easily accessible for you to sample. So that is one of the uses of PET in this setting.
Thank you, sir. That was a very elaborate discussion. So, with the CT thorax, in this particular sequence is only showing a large pleural effusion with collapse of the lung. So, I wouldn't spend too much time as sir has been elaborate, but our radiologists mostly felt because of the good arterial enhancement and a partial washout, maybe it was a cholangiocarcinoma is the differential that we got during our evaluation. And there were few just about significant type of lymph nodes seen in the abdomen. The MRI findings again, because of the atypical washout pattern, cholangiocarcinoma was given as a differential. Like sir correctly pointed out, there was a effusion which was bright, maybe it was hemorrhagic, was again suggested, and few enlarged lymph nodes. PET, the pleural cavity, the peritoneal cavity, and the liver lesion are all metabolically active on the PET. The tumor markers were negative. Could I ask Dr. Prakash to comment what as a clinician you would think at this point in time after the imaging details are available?
Yeah. So this patient, diabetic, alcohol use disorder, having chronic problem with chronic liver disease, and as a lesion in the liver. So whenever a lesion is there in the liver, in a cirrhotic, we always think of hepatocellular carcinoma. But the imaging characteristics, the enhancement pattern is not at all suggestive of a HCC. So that is not the case. So with a capsule retraction and the enhancement pattern, probably cholangiocarcinoma is possible. But I also don't have any information whether there is any focal biliary dilatation. Because with the cholangio, I would have expected some biliary dilatation, which was not there. Then he has got right pleural effusion, has got some sides. So the PET says that there is thickening of the. So was the MRI on CT showing that?
I have not shown the complete sequence for want of time.
Okay, right. So when there is an omental thickening and this, so the cholangiocarcinoma can metastasize into the peritoneum. So that can be a metastatic lesion. So even the pleural effusion. So it can be. So if you put it in one diagnosis, cirrhosis, cholangiocarcinoma or hepatocholangio or something with metastasis into the peritoneum. But whenever we have a patient with all these other underlying issues, we should also think of tuberculosis and with the pleural effusion and omental thickening. Omental thickening is something which is striking me because we usually do not see that much in a cholangiocarcinoma. So when that is there with this patient and has got ascites, then we need to do something more to clinch a diagnosis.
So our working diagnosis again was similar along the lines that I discussed. A decompensated liver disease, portal hypertension with a liver SOL, probably cholangio or atypical or a cholangiohepatoma was a working diagnosis. With a malignant pleural effusion bar pleural TB was the working diagnosis at that point in time. Could I ask the surgeon's input now, Dr. Gautam? So what would you do now?
So I think still there is some discordancy. We don't have a 100% accurate way of telling what the lesion exactly is. We haven't transitive ascites, CLD background, capsular retraction. So it's going in all directions. So histological diagnosis is must, and given probably the imaging, if we have the omental or peritoneal nodules, whether they are accepted. But I think even if you are thinking it's malignancy which has disseminated, there's nothing wrong in putting the needle directly into the liver as well.
So actually, like sir suggested, we had actually biopsied the omentum. We didn't biopsy the pleura. We biopsied the.
What was the INR?
INR 1.2, sir. So we biopsied the omentum. We did a bone marrow, but I'm focusing on the liver biopsy. images now. Ma'am, depending on Dr. Shirley, as you say, I could change the slides when.
Yeah, sure. So here this is a linear core of tissue. Here you can see some amount of hepatocytes. What is striking in this is, there is some steatosis as well. But what is striking here is this fibrosis. I think this was something that was already picked up in the imaging. So there is dense fibrosis and vague, vague storiform pattern, I would say. And there is some mononuclear infiltrate at this magnification, that's all I can say. Next slide. Yeah. So here this is something, where we are having predominance of lymphocytes and plasma cells. And here you can see this fibrosis. It is kind of forming a pattern, some kind of a whirling pattern or a storiform pattern, that's what I would call it. But no obvious granuloma is seen. Whatever he's seeing here as well, there is no definite epithelioid cell clusters or histiocytes to suggest that there is any formation of granuloma. So all I can say is that at this point there is dense fibrosis having a storiform pattern with a prominent lymphoplasmacytic infiltrate, and whatever blood vessels I'm seeing here, there is no perivascular cuffing of lymphocytes or anything, because I'm kind of looking for one particular feature that is not there in this. Yeah. So here you see this, this is very characteristic, the storiform fibrosis. It's kind of forming a whirl. All the cells are radiating out of, like a hub and spoke. I don't know. It's not working. The pointer is not working, yeah. So, this storiform fibrosis is very classical of this mass, this lesion that we are seeing here. And there is a very prominent lymphoplasmacytic infiltrate. But again, I'm not sure whether there was any portal tract or bile duct included as part of the biopsy, because those pictures.
It was from the lesion, so we didn't get a normal.
Okay. Because normally in this condition you would see that the bile ducts are spared and some periportal inflammation also would be there. Yeah.
Anything particular on this slide, no? Or I'll just.
No. I think it's a lymphoplasmacytic rich infiltrate, and with all those fibroblasts. I think there was another slide on. Yeah. So this is immunohistochemistry for SMA. So all the brown stain that you're seeing are the myofibroblasts, which are positive for smooth muscle actin. So essentially it just tells you that this stroma, this fibrous stroma that you're seeing is composed of myofibroblasts. So then the next differential comes in. So should I proceed or you will go on?
No. What's your final take, ma'am? What did you think?
Yeah, so whether it was IgG4 related disease, and of course the close differential would be an inflammatory myofibroblastic tumor. So that's why. No, we don't see, but at least 2 criteria is sufficient. Yeah, so the 3 criteria for IgG related disease would be a storiform fibrosis, a dense lymphoplasmacytic infiltrate, and obliterative phlebitis. So that's why I pointed out that the blood vessels that were present here were apparently fine, but at least 2 criteria should be there. And of course, estimate the number of those plasma cells, how many of them are IgG positive, and out of those, how many are IgG4 positive, and estimate the ratio.
I have purposely missed the IgG4 staining because that was negative in this case, so I didn't concentrate on that. I'll finally come to what our pathologists felt. Our pathologists agreed with all the findings that ma'am has pointed out. They said it's inflammatory rich fibroblastic proliferation with no evidence of carcinoma. And at this point in time, we did not have any evidence of a neoplasm nor any particular tumor. So, like I had mentioned, we had biopsied the omentum, the bone marrow, the liver, and the pleural and ascitic fluid for MZ and expert, and all of which were negative multiple times. It was just chronic inflammation, and that was it. So there was no malignancy, there was no.
Yeah. So ALK is positive in only up to 50% of inflammatory myofibroblastic tumors, and the technique that is done here is immunohistochemistry. So it depends on the clone that you use. If it is ALK1, the sensitivity is less compared to D5F3. That is another clone that is used to detect ALK protein.
Yes.
But even then, if it's negative, the next best way is to look for rearrangement. Do some fusion studies. Fusion studies, and look not just for ALK, but for ROS and NTRK. These are all the other fusions or translocations that occur in inflammatory myofibroblastic tumors.
This for MGS, for ALK fusion and NTRK fusion and gene rearrangements.
Yeah. ROS alterations.
Thank you, ma'am. So Now I would like to request both the physicians and the surgeon, what would Dr. Vikram, sir, what would you do, sir, at this point in time?
No, so the patient's problem is that his liver is decompensated. I'm still not convinced that we have tuberculosis or anything there. So, okay, a fancy rare tumor, we are happy for him that has caused his, but his problem is he has come to you with ascites for 8 months. That is the patient's problem. And then luckily you have not found any malignancy, so we will treat the patient as per his complaints. So for me it is medical management. Obviously I am not operating on a decompensated cirrhosis.
Dr. Prakash, sir?
Yeah, of course he is not a candidate for surgery at this moment because it's a huge lesion and that cannot be operated and the liver remnant would not be there, then he says so surgery is out of question, so we will just manage.
Nothing to add.
Sir, the surgeon also agrees with physicians rather. So we had asked multiple departments for their opinions as well. So pulmonary medicine felt that the pleural effusion is got secondarily infected, but the primary cause of pleural effusion may have been only malignancy. And they wanted us to cover with antibiotics for 10 days. Our surgeons have said, of course, patient is not a candidate for resection at this point in time. Medical oncology, we had asked if inflammatory myofibroblastic tumor had a particular chemo regimen that potentially could benefit, but they were not happy with the biopsy. At the same time, he was not a candidate for chemotherapy as well. So what we did is we thought he is not fit for resection. In view of concern of malignancy or infection, he was not a candidate for liver transplant at this point in time. And we a working diagnosis at that point in time was inflammatory myofibroblastic tumor, and we decided to keep him on close follow-up. Just briefly, inflammatory myofibroblastic tumor is known by other names: inflammatory pseudotumor, plasma cell granuloma, fibromyxoid lesion. It's just like we saw in the biopsy, it's a spindle cell proliferation with variable amounts of inflammation, and it's a benign lesion but known to be locally aggressive. Rare reports of distant metastasis also been reported. It's a diagnosis of exclusion. Treatment options: resection, observation, various regimens of chemotherapy, radiotherapy, and systemic steroids all have been reported in few case series. So the course of management for the large pleural effusion, he became dyspneic in the ward. We placed a pigtail and he was symptomatically better, and after antibiotics he was sort of planned to be discharged, after which an OPD pleural drain came down and we removed it. He was, like Dr. Vikram had correctly said, we managed him symptomatically, he was happy. The diuretics with lactulose, he was comfortable and discharged. 2.5 months on OPD follow-up, though he was not symptomatic for much, he was okay with diuretics. We repeated imaging to see. Again, could I ask Dr. Karthik for his opinion?
Contrary to the first imaging, now if you see it's a T2 image and you are seeing areas of bright signal intensity within the lesion, the retraction has become more, and within the bright signal, if you carefully see, there are some areas of necrosis with some rim enhancement. So if we do a diffusion, we'll know probably whether it is an abscess or a necrosis based on how the values are. So essentially there is a dramatic shift in the morphology.
So there was a reduction in the size of the lesion with 2 new lesions looking like focal abscesses, and of course the effusion also, as in the full image, was reduced, right sided pleural effusion. So this question is Dr. Gautam. So I mean, we were thinking of a malignancy in the beginning. What are the lesions that potentially could decrease in size without any particular treatment?
Generally, if you ask me, then they are generally non-neoplastic. Okay, either it can be an infective or an inflammatory. So, infective abscesses, bacterial, viral, fungal, but to have a spontaneous resolution without any initiation of therapy is unlikely, unless you are looking for an immunocompromised individual who had a fungal abscess, actinomycosis, those kind of things. The other entities can be like inflammatory, IgG4 related, sarcoidosis, IMFT. So these are possibilities, but how often they show such a dramatic response without any initiation of treatment is questionable.
Thank you, sir. So actually, we were thinking maybe because he got a bit of antibiotics during a hospital stay, is this lesion is responding, and his pleural effusion also came down. So we were thinking more in terms of infection. This is also a CT just showing the same thing which we saw in the MRI. So question is to Dr. Prem sir. At this point in time, as clinicians, what would you do, sir?
Still, we don't have an answer now. So if it's going to be an abscess, what are we going to gain by doing a biopsy? Because it's spontaneous resolution. So if it's then a solid lesion, probably we can think in terms of a biopsy. But here, the abscess reduction in size. So I don't think low biopsy is going to help us much.
Yeah, at this point in time, sir, his bilirubin have reached less than 2. Albumin had picked up with good dietary advice. It was above 3, but still less than 3.5. INR is still about 1.2 to 1.4. It's come down to 250 range. Not normalized, but come down. So I'll just go to what we did. We thought because the lesion is changing morphology and there was an abscess, we thought if we put a needle, at least we can get a rebiopsy and take some fluid for MJet expert and fungal culture and routine culture. So we did a rebiopsy of the liver lesion and also got cultures. Again, I would like to request Dr. Shirley for her expert opinion.
So this is again, I think it's the same picture that we are seeing, similar to what the first biopsy was. Dense inflammation and fibrosis as well. But can you go up to the next? So we don't see any neutrophils. We were talking about abscess, but no neutrophils. But again, dense lymphoplasmacytic infiltrate. No evidence of any malignancy, no evidence of granuloma, and again the fibrosis in the background. So this is definitely, a fibro-inflammatory process, mass-forming lesion. So that is what I would opine at this point. And again, like I asked you whether IgG4 was done, because did the patient receive any steroids?
No steroids. No
steroids were given. Okay, because you said there was a dramatic response. So here, you can see these plasma cells that are really standing out. And lymphocytes, but there are no eosinophils and neutrophils are, hardly there. So it's a fibro-inflammatory mass-forming lesion. Yeah.
So thanks, ma'am. So we did the ALK D5F3 stain this time.
Yeah, that is okay. So CAM 5.2 immunohistochemistry is Karen. Okay, so immunohistochemistry, 2 markers have been done. So CAM 5.2 is an alternate clone of cytokeratin. So there are 2 clones. One is AE1/3 that is usually done, but CAM 5.2 is rather more sensitive to pick up any, if there was any evidence of malignancy, because I think we've been talking about malignant effusion, even though psychologically it was not proved at any point. And ALK D5F3 is what I was talking about, which is quite sensitive, and this is what is done in lung carcinomas when we are looking at, ALK by immunohistochemistry. So if ALK1, that was the other clone, that was negative, but sometimes ALK D5F3 is more sensitive, it picks up, but the caveat is that immunohistochemistry has its limitations. And like you mentioned, about chemotherapy, I would also like to say that there is, targeted therapy, crizotinib. So definitely if we do some gene fusion studies, I think that will give us more idea as to, an inflammatory myofibroblastic tumor. But IgG4 still remains.
Yes, so we had again, I think may have not been mentioned in the slide, but we have done IgG4 staining again, and there was not, it was not positive, and the number of IgG4 staining was 0 actually. So our pathologist again said the same thing, inflammatory myofibroblastic tumor is the possibility that they gave us. While he was there, we just wanted to follow up. Actually, it was not symptomatic for the lung, but we wanted to follow up on what's happening to the lung. So we did a HRCT. So the HRCT is, sir, would you like to come?
So random nodules are seen and some fractures are seen. I don't know whether you are able to appreciate from there. These are the nodules. Some patchy neoplastic. Somehow the nodules show small cavitation. That is old fibrosis and fading changes. So for us, in radiology, without the labs, just the morphology. Patient like this, we will think of septic emboli or some kind of nematogenous infection. That's what could be.
Thanks, sir. So, radiologists also concurred. There were multiple confluent nodules in both lungs, and the differentials that they had given at this point in time was a metastatic lesion or a chronic infection with a hematogenous spread. Dr. Vikram and Dr. Prakash, what would you do, sir, now? I mean, he's 3 months with us almost now.
No, I'm happy actually. I agree that we needed one more biopsy to be sure. So I'm always in favor of a second biopsy if the first is not there. So again, you see clinically the pleural effusion has gone. So for me, this practically rules out a malignant pleural effusion. Cytology was negative as said. Ascites has been mobilized. Patient is well. You are left with inflammatory myofibroblastic tumor in a background of cirrhosis and chronic pancreatitis and diabetes. Now, point is the decision here is whether you want to use steroids or you just want to let him be. Remission has been reported with either strategy. And now it's a risk-benefit analysis. I don't think we should be risking him chemotherapy. We haven't done fusions. And even if you do, he's not a candidate for any chemotherapy based on the background that he has. So let's not chase treatment which we will not give him. Steroids if possible, otherwise just manage him conservatively. And IMTs are known to resolve with both strategies as far as I remember.
Thank you, sir.
Yeah, he seems to have a spontaneous improvement over the course of time. So I don't want to alter this improvement course and give something. And also the CT has shown some possibility of septic MRI. So I am not inclined to give him steroids also. I just follow him up with whatever supportive treatment and aortic.
So for the lung evaluation, anything more should we do, sir? What do you think, sir? Because he's got.
So I was just asking whether is there a possibility of tuberculosis, but the radiology picture it doesn't look like that. Otherwise, as a clinician, I would have asked them to do a sputum AFB also if he is having cough. That's all.
So I agree with sir. So I agree with both Dr. Vikram and Dr. Prakash. So while we kept him an observation for the liver, we did an induced sputum because he didn't have any symptoms. We induced sputum, and this time around his sputum had come positive for tuberculosis. Both later on we found that MZ also had grown, and it was a sensitive bug. Because his liver was initially child C, then he became child B. We had started on levoflox, ethambutol, and tried to challenge with INH because we felt there was a disseminated disease both on either side of the diaphragm. 2 weeks into ATT, he presented to us with headache and vomiting, and we were clinically thinking most likely he would have had a ATT-induced hepatitis because we had put him on INH. So we were keen to admit him, check LFT, INR, and ammonia levels, which are all normal. He didn't have any flaps, but in the very same day he developed confusion and dropped his sensorium in the ward. So he was intubated for low sensorium and shifted to ICU. After which we transferred him for a CT brain, C-, which it's sticking out. Everybody can appreciate that is hydrocephalus. And because he had dropped sensorium, we called neurosurgery, who came and did an emergency EVD, and the CSF also had grown. Expert TB and MJET, which was time sensitive, and the glucose and protein was slightly low, protein was slightly elevated with only 15 cells with 85% lymphocyte. The cytospin again we checked to rule out malignancy, which is negative. So at this point in time, our working diagnosis was disseminated TB, both CNS, lung, and we thought probably the liver lesion. So we talked to our pathologist, ma'am, what would your comments be, ma'am? Do you think a liver TB could have an inflammatory reaction which can mimic a myofibroblastic tumor because there's so much inflammation and so much fibrosis? Could this be liver TB?
But without seeing any evidence of necrosis, at least on the biopsies that were done, and any evidence of granuloma, it's hard to say. And in tuberculosis, generally we don't see so much of fibrosis and lymphoplasmacytic infiltrate. That is quite unlikely. So, in both the biopsies, there was no even a slight hint that it might be a tuberculosis. There were hardly any histiocytes as well.
Was there any point in doing a biopsy from the other side that is not from the lesion, whether it's an infiltrating?
Other normal liver is asking.
Yeah, so whether it was an infiltrated disease. Okay, because even in the early LFT, it showed a called alkaline phosphatase elevation. But later on, the alkaline phosphatase had come down, but it had not returned to normal. That's what I presume. Yeah.
No, sir.
Inflammatory mass in the
So
liver.
I think our enigma continued whether it was a inflammatory myofibroblastic tumor, but when I spoke to my pathologist, he felt chronic TB in the liver, abscess with peri-lesional fibrosis. If we got the biopsy from the fibrosis, it may look like this. So of course he was also not convinced, but as clinicians we felt maybe was it all TB to start with. So I don't have an answer for that. So the liver SOL case still remains as a working diagnosis of peri-inflammatory myofibroblastic tumor or a TB with inflammatory reaction around it. So I don't have a conclusion to that. But patient's course was downhill because though he was intubated and shifted to ICU, he added rifampicin and dexamethasone, later on added pyrazinamide. Despite EVD in place, he never had improvement in his sensorium and subsequently lost his brainstem reflexes and succumbed to the illness. I mean, if there's time, any closing comments from the panelists?
Sir, I just have one question for the radiologist. I think they had the suspicion of cholangiocarcinoma. Why was it, sir?
No, because cholangiocarcinoma is a serous tumor, predominantly
Only
serous.
that.
So any fibrosis will behave like this. In fact, for lack of time, I didn't go it. Once you see this pattern, it's called a targetoid pattern in diffusion, and so the differential diagnosis will be on the malignant side, cholangiocarcinoma, sarcomatoid mixed HCC, and on the benign side, if you see, it will be an IgG4 or an inflammatory myofibroblastic tumor. Inflammatory adenomas can be like this. The most important thing is any mucin producing tumor, especially colonic MITs will look like this. So these are the common things. And retrospectively, I think on the PET you showed, there was an uptake in one of the vertebra. So probably that and the mediastinal nodes, if it is showing a rim cacheating necrosis, maybe.
So we never had cacheating necrosis ever in any of the biopsies. So
No, the reason I asked for that was because, IgG4 related. Of course, now you have proved that it's not IgG4. The cholangitis, associated with IgG4 can have a period of mass forming, which can mimic a cholangiocarcinoma on the imaging. So that's the reason
So if you stand back and look in something in HIV, immune reconstitution, and then we know that immunocompromised patients will have tuberculosis with clear lungs, and once their nutrition and immune status improves, you will see infiltrates then. So this patient, honestly, and I think you did the right thing, had no evidence of tuberculosis, and in a decompensated cirrhosis, we should have a high threshold for ATT. But then I think possibly he may have had TB first, you did not see it, you gave him ATT, he developed a hydrocephalus because his subarachnoid, his ventricles, this thing scarred, they healed. He started developing manifestations. Once he mobilized his ascites, his nutrition improved, and then you started seeing the telltale signs of tuberculosis, maybe. It is obviously speculative.
So almost like how we see in
So our learning point is something which Dr. Epan tells us in CMC. For every malignant lesion, have a benign lesion as a differential. Always don't think it's the last page for the patient and don't upfront give a bad prognosis. So that was my take home from this particular patient. So I was even now thinking if I had given maybe empirical ATT in the early phase, maybe it may not have turned around. So, but this is, for the students in the audience, this is not a usual case. It's a very, exceptional case. It's not the norm. So, TB masquerading as a liver SOL is rare, but in my limited post-DM period, I've seen 3 patients. One chronic abscess which came out as TB, one more patient which expert TB came positive, but this patient recurrently biopsy was negative. So, I'm not sure whether this was TB at all. And of course, we had a chance to learn more about inflammatory myofibroblastic tumor involving liver. Thank you all for the patient listening.
So my talk will be about approach to pancreatic SOL. So brief history. 57-year-old male with complaints of intermittent epigastric pain of 1 month duration, which is increased for the past 5 days. Dilating type of pain radiating to the back. It was associated with multiple episodes of vomiting in the last 5 days. And there was a weight loss of 4 to 6 kilos in the last 2 months. There was no significant history of fever, jaundice, altered bowel habits, or overt GI bleeding. He is a known case of diabetes, hypertension for the past 10 years. Past history of ethanol consumption and smoking, stopped for the past 6 years. And he has a history of chronic calcific pancreatitis, diagnosed in 2019. And he had also undergone a pancreatic stenting for symptomatic pancreatic stones. And currently he is on pancreatic enzyme replacement therapy. It's a short history. And on examination, the positive findings were he had a mild pallor, he had tachycardia, and abdominal findings, there was a vague mass in the epigastrium. So, the summary of the clinical examination findings is he is a diabetic, hypertensive with a history of chronic pancreatitis, presently with abdominal pain, weight loss, and a vague mass in the abdomen, and with a past history of ERCP and pancreatic duct stenting. So at this point of time, I would like to ask the clinicians, Dr. Vikram Bhatia sir and Prakash sir, like what would be the possible differences, syndromic differences you would like to consider?
So 57-year-old male with chronic pancreatitis, diabetic, who has pain in the upper abdomen, but you also said goes to the back. And obviously he has a pancreatic disorder, so my differential would be disorders related to pancreas and unrelated to pancreas here. Related to pancreas with a vague mass, I would like to keep a possibility of a pancreatic cancer, a exacerbation with pancreatic fluid collection, unrelated to pancreas, epigastric pain in a diabetic patient, retronodal tuberculosis can cause pain radiating to the back. He is a hypertensive, even though you say the mass is not pulsatile, but aortic aneurysm is also in such cases at least should be thought of and looked into. And I think that's the things. Once you tell me a mass, obviously it can be unrelated, a gastric mass or other, but he had no vomitings or other gastric. He had vomiting.
Yeah.
So
Vomiting was only short duration, 5 days history of.
fair enough. So like undergraduates, we think of the things related to pancreas and other organs in the epigastrium, which is stomach, colon, and obviously the retroperitoneum. In this scenario, I think I'll talk of aortic aneurysm, nodal TB, and a pancreatic mass in the reverse order.
Yeah, again the same thing. Person with chronic calcific pancreatitis, diabetes, but the symptoms of pain recent onset and weight loss for the past 4 months. So whenever we have a chronic calcific pancreatitis with recent pain, apart from the exacerbation of pancreatitis, we also think of malignancy. So whenever there is a recent increasing pain or pain present but became better and now having worse pain or a persistent pain or a recent worsening of diabetes which we don't have any, or is something which we think of malignancy, or any jaundice. So here there is no jaundice, no recent worsening, but history of weight loss and a recent abdominal pain. So malignancy, of course, is something because of the weight loss. I would keep that as my first thing. Second would be an inflammatory lesion or probably a fluid collection or a thing. And then maybe because he has been alcohol use disorder, earlier diabetes or any other causes like tuberculosis or lymphoma or anything. So, but probably mainly my focus would be on pancreas related issue, malignancy or an acute exacerbation.
Our differentials were on the similar lines. Initially we were thinking in terms of malignancy and also acute exacerbation with pancreatic fluid collection. So coming to the labs, the relevant labs, he had a neutrophilic leukocytosis with a mild anemia and thrombocytosis. And the LFT showed a mild elevation of the alkaline phosphatase and GGT and AG reversal. Apart from that, the labs were, the sugars were on the higher side, but we don't have a past history. What is the pattern of his sugars in the last 6 months? So ultrasound abdomen was done outside. He had just brought us a paper showing the report, which showed a chronic calcific pancreatitis with a really bulky head of pancreas and a PD calculi. And there was a prominent CVD. So what next? I would like Dr. Prem Kumar sir to see how do we proceed further. This is the labs and investigations we have, ultrasound done outside. So what is the next line of investigation we like to do?
See, we had a differential diagnosis of malignancy as well as a collection due to secondary to chronic pancreatitis. And here we have a elevated WBC count around 22,000 with elevated ALPOS and dilated CBD. So we'll have to do a contrast CT abdomen to find out what exactly the reason for the vague mass is there in the head of the pancreas, and then the malignant mass or a collection. I think that contrast CT will help us to find out the exact etiology.
So we did a CT abdomen. Dr. Karthikeyan, sir, your comments on the CT. I have the images, 4 images.
One of the easiest thumb rules for any radiologist and even to clinicians, I think when you send cases like this, the best thing a radiologist should do is go back and get the prior. He has had, because he has had multiple interventions in the past, I'm sure he has had multiple CTs. So one of the best ways when you deal with pancreas is you go through the old images if it is there. So in this case, it is not available to us. Again, you go back with the morphology. Currently only 2 images are given. One is in the head region. This is the venous face. So again, I'm not sure whether you are appreciating, the entire mass is enhancing. So again, we are dealing with something which is fibrosis. Speckled calcium is there on the periphery, and there is some amount of indentation of the duodenum. We don't know whether duodenum is involved. So coming to the lesion, what they have marked in the tail, see the morphology. There it is expanded, here it is not expanded, but lot of rhizomatous changes are there, like what you will see in a pancreatitis and it is not enhancing so much. So based on this, what I will think is probably is going in for some form of necrosis in the tail area, and because it is showing a delayed phase enhancement, with these images, any other images? Sure. So again, within the C loop, if you see, it is a well circumscribed mass. Even though it is involving the vessels, it is not causing constriction or a cutoff. Apart from that, if you see, there are few images where the adjoining is reaching the stomach and also reaching the splenic area. So looking at it, the pancreatic lesion in the head area probably is a focal chronic pancreatitis, because the C loop looks more or less okay in the coronal images, and what he has in the tail is probably a pancreatic necrosis.
So this is the report given by our radiologist. They had mentioned it as an enhancing mass lesion in the head of pancreas, encasing the celiac, common hepatic, mesenteric vessels and portal confluence. In addition, the mass appeared to be causing significant narrowing of the proximal splenic artery, superior mesenteric vein and occlusion of the splenic vein. Calcifications were noted within the mass with small areas of necrosis in the posterior aspect. So another mass lesion with similar appearances was seen in the pancreatic tail, which encased the distal splenic artery. Enlarged lymph nodes in the lesser omentum and peripancreatic region around the pancreatic head. The tumor markers were done as there was a suspicion of malignancy. It was normal. So I would ask Dr. Prakash sir, so this is where we are after the clinical history, labs and imaging. So how do we proceed further?
So this patient has chronic calcific pancreatitis with mass, 2 different types of mass. One is in the head, the other is the tail, where it looks like more of an inflammatory mass. So if he had a previous CT images, it would have been very good, because those calculate whether it has been displaced. So if it has been displaced, then a possibility of a tumor is very high, because that is something which we should think of. But the enhancement pattern which has been described is not like a usual pancreatic malignancy. So it's more of enhancing lesion. So there is some discordance in what we see in the imaging. So the next, I would always think of a mass lesion in the head, though there is a difference in the enhancement, and the calcification seems to be in the periphery. So I will not say that it is just an inflammatory, but a malignancy has to be ruled out. So we need to get a tissue diagnosis so that we will be able to go ahead and do something.
So actually, we had a discussion in our team with the radiologist and our surgeons, and as the CT features were not very typical of malignancy, we had one lesion in the head, one lesion in the tail, and the history and features were not collaborating. So finally, we also decided to see whether we could get a tissue diagnosis. Hence, we proceeded with the next line of investigation. We thought since it's from the pancreas, we'll use an endoscopic ultrasound and see whether we can get a tissue for diagnosis. So the EUS, some of the representative images. So we could see a very hypo-enhancing mass in the head of pancreas and the similar lesion in the tail with some calcification. So what's the EUS findings? The hypoechoic ill-defined mass measuring 5.8 into 7.2 centimeters and 5.5 into 5 centimeters in the tail and head of pancreas, encasing the portal and splenic vein. Features of chronic pancreatitis are also seen. So I would like to ask Gautam, the surgeon, is there a need for biopsy or should we consider any intervention?
As a thumb rule, I just keep 3 pointers. If there is high risk of malignancy or a proven malignancy, if the patient is symptomatic, and if there is an acceptable morbidity due to surgery, then we can consider surgery. In this scenario, one, the patient there is no high risk to say that this patient has malignancy, and if you ask me the morbidity, patient has got all the vessels involved. There is no question of surgery at all in this patient. Second, yes, I would prefer a biopsy. Just before that, I would also like to know how good is CT perfusion or any EUS elastography will be as an adjunct in differentiating this. I will want a biopsy, but just
no, essentially it will be confirming the nature of the lesion. If you do an elastography or a CT perfusion based on it, probably again we will conclude it as some kind of a fibrotic lesion or an inflammatory lesion.
In the setting of chronic pancreatitis, elastography we have a very less sensitivity. You might look at the strain ratio, which may be more, but even then it doesn't give us anything. We need to get the tissue.
So we proceeded with the EUS guided fine needle biopsy. And Dr. Shirley, your comments on the slide. Actually, we have only one slide because.
So I think one slide says it all. So what we are seeing is basically all the light pink areas that you're seeing is blood clot, predominantly fibrin threads. And in the center what you're seeing is the dark, hematoxyphilic or purplish materials that you're seeing are all filamentous bacterial filaments, Splendor Hopley, that is very characteristic of actinomycosis. And that is exactly the center of neutrophil, an abscess kind of a thing. And there is, I think, a neutrophil rich background in the middle of which you're seeing that Splendor Hopley. So this is actinomycosis.
Thank you. So this is the report given by a pathologist. Shows fragments predominantly composed of fibrin and blood clot, dense acute inflammation composed of numerous sheets of neutrophils, lymphocytes and panchy lymphoid aggregates. Amidst these inflammatory cells, many basophil Basically, PAS positive, gram-stain positive bacterial colonies with radially branching filaments consistent with actinomyces were observed. And as Madam had highlighted, the splendor of poly phenomenon. So the diagnosis was actinomycosis. It's a pancreatic actinomycosis. So what would be the treatment approach to this patient? So this question is open to both.
Actually asking the wrong person. I haven't even heard, least often seen a pancreatic actinomycosis. But what I remember from undergraduate, the treatment was, and anybody can correct me, penicillin G for a long time. Maybe now cephalosporins, tetracyclines, what else? Clindamycin. But I may be wrong here, I'm sorry. So there have to be someone wiser than me. What is interesting here is that how in the world did actinomycetes get inside? Usually it is with trauma and other abrasions. So the only trauma to the pancreas I see is pancreatic stenting. Now whether your stenting is introducing actinomycetes in it, I'm sorry, I can't say anything more than that.
Actually,
but I think the patient needs a prolonged course of antibiotics from penicillin or cephalosporin group of drugs for a couple of months. But we'll have to refer to the textbooks for exact regimes.
And Dr. Gautam, do you think there is any role for surgery at any point in abdominal actinomycosis? Is there any indication for surgery?
See, generally we come across it when we post appendicectomy, we have a stump blow, then we do have this issue. But even then, if the patient develops an atrial fistula, medical management control of actinomycosis followed by a limited ileocecal resection for a persistent fistula will be the way treatment. I think same will be here. But to be frank, only with imaging we'll know whether how much is the response with the patient. Then we can take it.
So the patient was treated with IV third generation cephalosporins initially for 6 weeks, followed by oral antibiotics for another 6 to 8 months. He had a very good clinical resolution of symptoms with weight gain and a repeat CT. It was done outside. Short only features of calcific pancreatitis with mild fat standing. All the mass lesions what we saw in the previous CT completely disappeared, and there are very few insignificant nodes seen. So the final diagnosis was pancreatic actinomycosis. A small discussion on actinomycosis. It's a rare subacute to chronic granulomatous and separative infection caused by gram-positive filamentous, non-acid-fast anaerobic bacteria. They are usually commensals in the oral cavity, GI tract, and female genitourinary tract. Recent incident data is lacking, but generally males are more affected than females. The peak incidence is 40 to 50 years of age group. The common locations are, the most common is orocervical because of the poor dental hygiene, and thoracic actinomycosis in 15 to 20%, abdomen and pelvis 20 to 30%. The risk factors are cervicofacial due to poor oral hygiene and dental surgery, pulmonary usually due to aspiration of oral and GI contents or an underlying lung pathology, abdominal, the most common is post-appendicectomy in the ileocecal region, then inflammatory conditions like pancreatitis and foreign body insertions like IUD insertion or endoscopic interventions. Even ERCP is supposed to, because it causes a mucosal breach which serves as a portal of entry. And in this patient, he had an ERCP, and he also had an immunocompromised state in the form of diabetes. And so pathophysiology, it enters the tissues following a breach in the mucosal lining. Infection is established by inhibiting the host defenses and reducing the oxygen tension. It is followed by an intense inflammatory response, which is suppurative and granulomatous. It spreads and infiltrates in a contiguous fashion, inducing a strong desmoplastic reaction. It does not respect the tissue planes. And finally, it results in draining sinus tracts, yellow clumps, and intense tissue fibrosis. So why does it look like a mass? Because of its slowly progressive, as it spreads, it infiltrates tissues in a contiguous fashion. It does not respect the tissue planes, and because of the strong desmoplastic creation with the central typically undergoing lipifying necrosis. These features results in actinomycosis masquerading as malignancy, especially when involving the abdominopelvic viscera. Abdominal, as I told you, the common sites for abdominal actinomycosis is the ileum and ileocecal region. Pancreatic involvement is rare, but it tends to occur following abdominal surgery or in the setting of previous pancreatic duct stenting and chronic pancreatitis. So the presentation can be very non-specific in the form of fever, vomiting, altered bowel habits, sometimes in abdominal pain with or without a mass. And in advanced cases, you can have sinus tracts, fistulas and abscess formation. Imaging, again, CT can be very non-specific and it can mimic other conditions, unless you have findings like fistula, multiple abscesses in chronic cases. The gold standard is a tissue biopsy and culture. EUS can be useful if the location is amenable for acquiring the tissue. Microscopy, as we've already discussed, I think Madam has already highlighted the findings. So the treatment is usually high dose penicillin, or if you feel there is a high resistance to penicillin, you can go for third generation cephalosporins also. The duration is usually 6 to 12 months, or as per the burden of the disease. Surgical resection is usually very adjunctive, only in select cases where extensive necrotic tissue or fistula are present. Otherwise, the main line of medical management is medical management. So this was our differential diagnosis. There was 15 case reports previously reported, and all of these cases, the preliminary diagnosis was a pancreatic malignancy. Conclusion: importance of considering treatable non-malignant causes in differential diagnosis of intra-abdominal masses. Rare infective causes like actinomycosis should be considered in patients with previous history of surgery, endoscopic intervention, and immunosuppression. That's it. Thank you.
Of high order. I was just wondering to ask, how often do you find a mass in pancreatic malignancy? No? Seldom we find a mass. Mass in pancreatic malignancy is uncommon. It's more of cystic neoplasms. So I think, would you agree to that, sir? Mass is a presentation pancreatic malignancy. Seldom we find a mass.
Yes, a palpable mass obviously would be later.
Yeah, I mean, mass would present obstructive jaundice, and most of the masses we seldom find it as
it's very rare to be able to palpate a pancreatic head malignancy because they would have jaundice far before anything is palpable. For pancreatic body tumor in a very scaphoid abdomen, you can have some impression, but madam, you are absolutely right. The cystic tumors, certain types which are clinically palpable, it would be very unusual for a pancreatic mass per se to be palpable clinically.
radiological mass. Radiological, yes, but not
no, palpable mass, madam saying.
Mass clinically is more infective or inflammatory.
Yes, and or cystic tumors.
Or cystic tumors.
Cystic tumors which we can clinically palpate.
I think both the cases were well dealt, and I think one of them should go for the gastroenterology session, at the ISG, the first one and the second one. Both were of high order. And we thank the panelists for a wonderful discussion. We learned a lot, and especially Dr. Shirley, we learned something more about inflammatory myofibroblastic. Thank you very much. Thank you.
All the participants for making this medical education program really useful to others. So to start with, I thank the participants, postgraduates, panelists and chairpersons, and our guest speakers from outside Chennai and from Chennai. I would like to invite the presenters to get the certificates. I request Professor Padmanabhan to give a certificate to Dr. Anbu Kritiga. Please come in. Dr. Somnath Verma. Dr. K.R. Panichami. To facilitate Dr. Vikram Bhatia.
Dr. Prakash Akriya, sir, please. Dr. Jayanti, madam, you can please. I will request Dr. Jayanti madam to felicitate Dr. Shirley as well. And request Dr. K.R. Palniswamy sir to felicitate Dr. Karthikeyan. Dr. Gautam Krishnamurthy as well. Dr. K.R. Palniswamy sir, please. Thank you all, and thanks to Torrent Pharma and Lambda. And we are sure that today's CME was the best, and we had a lot to learn. With that, probably we'll disperse and we'll join for a cocktail dinner. Thank you.